Hello, doctors. Welcome to part 2 of discussion of diabetes mellitus. In this video, I'll be catering to long-term management of type 1 and type 2 diabetes. But over and above this, I'll also be catering to very cliche topics that the examiner wants to listen to. That would be like Somogai phenomenon in comparison with Dawn phenomenon. And as such, diabetes is not only to be considered from the perspective that blood sugar is elevated, but it also contributes to multiple other metabolic problems ranging from deranged lipid profile, which contributes not only to coronary artery disease but also contributes to fatty liver. In fact, in India now there's like a booming epidemic of non-alcoholic fatty liver disease, and a large number of these patients would either be diabetics or would be pre-diabetics. So we need to treat the disease overall as a whole perspective of how it is affecting the metabolic profile of a person. And I'll begin this discussion by first focusing on a complication of type 1 diabetes mellitus, that's diabetic ketoacidosis. In fact, in case you are listening to this video directly, my humble request would be please listen to part 1 also, so that you can understand the pathophysiology of the disease and the subtypes of various types of diabetes, ranging from type 1, 1.5 diabetes, type 2, and MODY. And then you will be in a better position to understand the aspects that I'll be discussing in this video. Now, I have an 8-year-old child who's admitted with a diagnosis of pneumonia, and he's already on IV antibiotics for past 3 days. And since last night, he's been having multiple vomiting episodes. So maybe the doctor on duty had already advised the nurse to give perinorm, that's metoclopramide, for control of vomiting, but the vomiting episodes have been persistent. That's what the second line is trying to say. And the child is also having severe abdominal pain, and the mother is noticing that the child is very drowsy. You see, every mother always has that sixth sense about a baby that the child is not fine. So she's telling me in the morning round that, doctor, my child is very drowsy and like the child is not recognizing me. So like I asked her to wake up the child, and she's shaking the child and calling out the child by the pet name. Like every mother will have a pet name for her child. So she's trying to call out the name of the child, but child is not opening his eyes. And she's saying like last night at least he was opening his eyes, but or he was giving me a blank look or a stare kind of a look. But at this moment, doc, he's not even opening his eyes. So I realized that there's something seriously wrong. And since it is a diagnosed case of pneumonia, what I was suspecting in my mind was that probably the pneumonia part has deteriorated. The patient has gone into a possibility of sepsis or septic shock. And I just checked out the vitals. The pulse rate was like half fast, 110 per minute. BP was on the lower side. That I thought is probably because the child was vomiting since last night, so the dehydration component could be contributing to it. The respiratory rate is 20. That's understandable. Any pneumonia patient will be hyperventilation. And I also noticed some epigastric tenderness when I was doing a per abdominal examination. Now, because I was first thinking that this child's original pneumonia episode has deteriorated, so I decided to just check out the pulse oximeter of this patient. And what I found was that the pulse oximeter report was showing me a report of 98% on room air. So I was thinking to myself, this is unlikely to be hypoxia, which is contributing to this drowsiness and altered sensorium of the child. Then I thought that maybe the pulse oximeter reading may not be so accurate, and why not let's do a ABG report of this patient as well. And when I looked at the ABG report, the pH in the question or pH in the actual practice scenario was turning out to be less. There was acidosis. So I was thinking it would be probably respiratory acidosis, but to my surprise, the carbon dioxide values were also lesser. Traditionally, in respiratory acidosis, carbon dioxide in the blood should be more, but here CO2 was lesser. That can be explained by the fast breathing that is occurring in this patient. And that also rules out the respiratory problem, because if it's respiratory acidosis, PCO2 should be elevated. And then the only possibility left is metabolic acidosis, and the bicarbonate value in the patient was very low. Normal is in the range of 22 to 26 milliculents. Here, the value given in the question would be like 10 or 12 or 15. So there's like bicarbonate deficiency present or bicarbonate deficit present, which tells me that my patient is having metabolic acidosis. Now, that's very surprising for me as a doctor, because traditionally in a pneumonia case, I expect a respiratory derangement to be present, but the ABG report of this patient is showing presence of metabolic acidosis. So I decided to do further investigations of this child to find out, why has it deteriorated so bad that he's not even in his senses. When I checked out the random blood sugar of this patient, when I did the metabolic profile, the random blood sugar was shocking 300 milligram, which is obviously very high. And along with that, the dipstick was used to evaluate the urine for the presence of ketones, and the keto sticks was showing 4 plus report. And then I also got a plasma beta hydroxybutyrate values done that was grossly elevated. So you can see that the triad or diabetic ketoacidosis is getting satisfied, that the random blood sugar is turning out to be more than 250. Along with that, the ABG is showing acidosis, plus there is presence of ketonuria in this patient as well, along with ketonemia. In fact, you can see I have demonstrated both ketonemia as well as ketonuria in this patient, along with low bicarbonate, which tells me there is acidosis plus random blood sugar is elevated. So the clinical diagnosis of this patient is diabetic ketoacidosis. And I'm thinking to myself, am I right? Like, when I'm going to tell the mother that your child is a diabetic, she's going to be like, are you kidding me, doctor? I mean, my child is 8 years of age, 8 years by diabetes. Okay. And she says there's nobody in a family who's having diabetes. You see, diabetes mellitus type 1 does not have a family history also. So you as a doctor can understand, okay, the technicals of diabetic ketoacidosis, the triad of diabetic ketoacidosis is getting satisfied. But to a non-medical mother, it would be like a shock, that there's no family history of diabetes, and suddenly doctor is saying my child is a diabetic, and the child is being shifted into intensive care unit from the general ward. This is because of the deterioration. See, pneumonia is causing triggering of diabetic ketoacidosis, because pneumonia is a condition which is stressful, so the energy requirements of the body will increase. This was an undiagnosed case of type 1 diabetes mellitus, in whom, because there is deficiency of insulin, so sugar cannot go inside the muscles. If sugar will not go inside the muscles, how will muscle get energy? There would be burning of fats, there would be subcutaneous fat oxidation that will generate ketones, and ketones are like highly acidic. That's why the patient is deteriorating. And it is good that the child was diagnosed today, because if this diagnosis would not have been made, then there can be a possibility of death in diabetic ketoacidosis as well. And they've asked what is the reason for this death. So metabolic acidosis causes damage to the blood-brain barrier. This would contribute to development of cerebral edema. So there are two primary reasons why these patients would die: cerebral edema and the dehydration component. And out of the two, if they ask you what is the most common cause of death as far as diabetic ketoacidosis in children is concerned, because decay is more common in type 1. It can occur in type 2 also, but is more common in type 1 diabetes. So especially with respect to a child with diabetic ketoacidosis, the cause of death would be a cerebral edema. And the triad is being satisfied in this case, that the blood sugar is elevated, that's more than 250, plus ketonemia, ketonuria is there, plus metabolic acidosis, because the ABG report shows the same as well. So this would be, first time when you diagnose a decay, it would be like suddenly a shock for a doctor as well, that we were anticipating that pneumonia patient would be having a pneumonia based derangement, in a sense that the patient could be having a respiratory acidosis, but turned out to be a metabolic acidosis. Initially, when he was having epigastric tenderness, I also thought that maybe he's having gastritis. He is having a gastritis due to the medicines that we're giving for treatment of pneumonia. Initially, I was also thinking it can be atypical pneumonia, because atypical pneumonia can have GI complaints also. So my thought process in the first 4 lines of the MCQ could be: one, it is atypical pneumonia, or it could be pneumonia showing a deterioration. The original pneumonia episode is showing a deterioration. The GI complaints can be explained by atypical pneumonia as well. Though finally the diagnosis is totally different, but initially I thought maybe because the child is on strong medicine, so there is gastritis component. And lots of times the abdominal pain in these patients can be so extreme that a large number of these cases can be misdiagnosed as even having acute abdominal emergency, like acute pancreatitis. But anyway, like the ABG report, the ketonemia and the ketonuria component and the random blood sugar have finally helped in arriving at a diagnosis. There's a separate video on the topic of diabetic ketoacidosis as well, which I would like you to listen once you're done with this video. And you see, in this MCQ, the pointer which is traditionally given in earlier times was not given. I mean, had this MCQ mentioned that the patient is having acidotic hyperventilation, and if small breathing was given in the question, then it would have been a piece of cake. Then there was no point of getting into all these ABG aspects, etc. I mean, if this question began by saying fruity odor in the breath of the patient, which is due to acetone, and the question simultaneously mentioned presence of small breathing, then this would have been a super easy question for any doctor to clear in the exam or to answer in the exam. That is why you will notice that in a large number of these questions, technical terms like acidotic hyperventilation, fruity odor in the breath would not be given. If he says what is the best test to confirm the diagnosis of diabetic ketoacidosis, then there are a total of 3 ketone bodies. It is acetone, acetoacetate, and beta hydroxybutyrate. And out of the three, the most acidic ketone body is what I'm interested in. This levels would be grossly elevated. Plasma beta hydroxybutyrate levels would be checked, and we'll see gross elevations in this patient. If he says what is first line treatment for diabetic ketoacidosis, then your answer would be we will give normal saline. That will correct the dehydration component. That will treat the hypotension component in this patient as well. Because of the GI losses, he or she, the child will be having hypokalemia as well. So we usually add potassium chloride to the bottle of IV fluid itself, usually like 40 milliequivalents per liter that would be given. And the advantage of giving normal saline is not only it will correct the dehydration component, but it will also cause dilution and decrease the severity of ketonemia, because ketonemia is the trigger causing stimulation of vomiting center, which was causing extreme protected vomiting that was persisting in spite of the fact that the doctor on duty at night prescribed metaperinom or metoclopramide for this patient. If he says what is the treatment of choice for this patient, then we need to provide the hormone that is deficient, and that is going to be insulin drip. So insulin drip is the main treatment that will shut down the factory of ketones. Because the moment you start the insulin drip of the person, what's going to happen is that the sugar will start going inside the muscles. You see, muscles want their favorite source of energy, sugar. If you were not providing sugar, they were burning ketones for, like, they were using ketones for energy production. Now their favorite source of energy is available because you provided insulin, and insulin will provide sugar entry into the muscle. So the ketone production, the ketone factory will stop. Also during treatment, you will notice that when you will start giving insulin, the sugar values in the patient to start falling less than 250. He says that don't allow it to go less than 200, and therefore you might also be required to change the fluid that you are administering to the patient once the values start going less than 250. Like in my case, it was like 300. So after 1 hour or so, when the values of blood glucose of the patient will begin to fall, then the fluid that we'll be giving to the patient will also be changed. That would be 5% dextrose with half normal saline. Half normal saline in MCQs will be written as 0.45% normal saline. I've already explained to you that in case we do not rush through the treatment that we're discussing at the moment, if fluids are not started in these patients, then cerebral edema will ensue, followed by concomitant dehydration. The dehydration component can then contribute to kidney failure, bubble infarction, multi-organ failure can ensue. So that's why, a prompt diagnosis and rapid treatment is to be instituted. And what is the trigger? Then the common triggers would be in the form of infections. It could be pneumonia, it could be urinary tract infection, it could be COVID-19 pneumonia, or in some cases, he might make it easier for you by saying that this child is already a diagnosed case of type 1 diabetes. The child is also on an insulin pump. Like insulin pump is technically called as continuous subcutaneous insulin infusion, but for a non-medical, use the word insulin pump. And this insulin pump is exhibiting a malfunction. That is one possibility. Or like this patient of type 1 diabetes mellitus was already started on insulin, but there was a non-compliance per se. You see, lots of time parents, once the child is diagnosed with DKA, we will discharge him on subcutaneous insulin to be taken like 3 times per day, the basal bolus regimen that I'll be teaching you. But they might be like negligent, or maybe there was a wedding in the family and therefore the child did not receive the injections of insulin as was required. So they would be, type 1 diabetes is all about insulinopenia. So if we do not give the requisite amount of insulin, then the child can land up again in an intensive care unit as well. So either it will be infection, or it's going to be like a insulin delivery that was less, either due to by chance maybe the child became sick, no, food poisoning. If this food poisoning, the child is vomiting, then mother did not give insulin injections to the child, saying that the child did not eat anything. Agreed, child has not eaten anything because of the food poisoning component, but diabetes is a condition where there's sugar everywhere. The sugar is not going inside the cells. So even if the child has not eaten, if the sugar is elevated, we need to give some insulin to the patient, because if we don't, then the muscles will start utilizing ketones for energy production. But ketones are highly acidic, and they'll bring down the pH of the blood, damage the blood-brain barrier, and create the mess that I have explained to you at the moment. I would like to add one point I'm not writing at the moment, that he says initially first give IV fluid and after 1 hour give insulin drip for this patient. Insulin bolus has been removed from the treatment of management of cases of diabetic ketoacidosis. So DK is like a complication that can be seen with both type 2 as well as type 1, more common with type 1. But don't be surprised if he mentions a type 2 diabetic patient who's having a heart attack or is having stroke or has undergone a surgery and then subsequently can land up into diabetic ketoacidosis. Let us now focus on what is the long-term management of type 1 diabetes so that such kind of mishaps do not happen. And the first and the foremost thing would be from like a pediatric perspective, type 1 diabetes, you would be giving insulin in the patient proportionate to the amount of carbohydrates the child is consuming. In type 2 diabetes, we go for calorie restriction. In type 2 diabetes, we go in for carbohydrate restriction, but in type 1 diabetes, we don't go for carbohydrate restriction, we rather go for carbohydrate counting. What I mean by carbohydrate counting is like suppose the child is eating aloo paratha in the breakfast in the morning and he found it that it is very crispy and very nice. All mothers will be making always very yummy aloo parathas for their children. So child found it tasty and therefore he requested the mother, I want to have a second one. So we will tell the mother, give the child whatever he wants to eat. If he wants to eat a second aloo paratha, cool, not a problem. But you will have to then increase the dose of insulin that has to be given to the patient to metabolize the carbohydrates that were present in that aloo paratha so that the blood sugar does not spike. So because if we do calorie restriction in type 1, then it will result in growth retardation. So the message is in type 2 diabetes, we go in for calorie restriction, but in type 1 diabetes mellitus, it is carbohydrate counting, and we need to increase the dose of insulin proportionate to the amount of carbs the child is eating. Along with this, moderate to vigorous physical activity would be required. Usually, like the child can play cricket and football, like about 60 minutes of aerobic activity would be recommended on a daily basis in these patients because we want to burn these calories as well. And unlike in type 2 diabetes, where I will say like 30 minutes of mild to moderate, there I will say mild to moderate, here I'm saying moderate to vigorous physical activity would be required because I want the muscles to utilize whatever sugar is available to this patient which the child has consumed, and for allowing that sugar to enter into the muscle, obviously what is required is insulin. Now the insulin that is available nowadays is manufactured by DNA recombinant technology. That's why we're gonna call it human insulin. You see, when I was a student at your age, at that time, the types of insulin that were available were like beef insulin, pork insulin. So ours is like a religious country. So one was obviously the resistance that you have to take injections of insulin. And second was that it is derived from like beef and pork. So people were not very, very comfortable. But now it's like human insulin, which is manufactured by DNA recombinant technology. And this would be like a polypeptide chain identical to whatever endogenous insulin would be produced from beta cells of pancreas. Now, how would we be giving insulin to this patient? Then the preferred route of delivery would be subcutaneous injections. If he says what is the preferred site and where we can give it, so I'll describe multiple sites before you, but one of the preferred sites would be the anterior abdominal wall. This would be peri-umbilical, about 2 centimeter away from the umbilicus of the patient. And if he says what is the preferred method of delivery of insulin, then our answer would be given as CSII. What I mean by CSII in a casual English terminology would be an insulin pump. This would be a microprocessor based device in which we will have to, there's a cartridge available which has to be loaded, but then this will deliver insulin in the body of this patient subcutaneously. So this device will be the ideal way of delivery of insulin because like you see, when you and me are not eating at the moment, like I am teaching you at the moment, so I'm not eating and you are listening to me, you may be munching something, may not be munching anything. Even if you're not eating anything, still some little insulin is getting released from the beta cells of your pancreas, which is called as basal insulin. So this insulin will behave like this insulin pump will behave like an artificial pancreas, like it will deliver some basal amount of insulin. But the moment the patient will start eating, the sugar in the body will begin to start rising, and this computer will sense that the sugar is rising. I'll tell you how will it sense that rise of sugar. But the moment the computer senses that the sugar in the body of this patient is rising, or we can program the device with respect to the meal time. Like nowadays, we have a very big time game changer that's called as continuous glucose monitoring. You would have seen a lot of celebrities, no, a lot of athletes also exercising with CGM, continuous glucose monitoring. I mean, athletes are doing it obviously because they want to see how their sugar values are behaving. But if we are using CGM, that is continuous glucose monitoring in a diabetic, then this CGM device can be synced with the CSII device, that is the insulin pump, and the continuous glucose monitoring sensor will be providing real-time evidence to the insulin pump regarding whatever is the blood sugar value. If the value will begin to fall, the computer will shut down the delivery of insulin. The moment the sugar values will rise, the computer will resume the delivery of insulin, and it will also deliver insulin based on the rise of sugar values. Like suppose the patient is eating a chocolate, or let me say gulab jamun or something which is like very having a lot of sugar inside it. So if the sugar will spike, the computer will increase the delivery of insulin. If the sugar will begin to decrease, then the computer will also start decreasing the delivery of insulin. And if the value falls below a certain level of less than 70, then it will shut down insulin production also, or delivery also. So continuous subcutaneous insulin infusion is the best way for delivery of insulin in the patient, paired with a continuous glucose monitoring device. So I'll show you images for the same as well. But as far as the principles of management of type 1 diabetes are concerned, it's not carbohydrate restriction, it's carbohydrate counting, moderate to vigorous activity, and insulin to be given to this patient subcutaneously over the anterior abdominal wall, with the preferred route being CSII. Now, what are the sites for delivery of insulin? Then, as I explained to you, that the site would be about 2 centimeter away from the umbilicus. And then I'm just putting marks here, like this could be the morning dose of insulin. This could be the dose just before the breakfast, before lunch, and before dinner. And in some cases, you might even be giving is a bedtime insulin to the patient. So I can say like these could be the sites for Monday. And then I would move a little laterally. This would be for Tuesday. That would be like shots that are being given for management of diabetes of this patient. So the point is that we are changing the site of delivery of insulin, because you're aware that when insulin is injected at the same site again and again, it can contribute to development of lipohypertrophy as well. Therefore, because of lipodystrophy slash lipohypertrophy, the site has to be changed on a regular basis, and we can use the anterior abdominal wall, and we can even use the anterolateral aspect of the thigh, or we can be using even the anterolateral aspect of the arm. And in some cases, like in lots of time in India, another child might be very skinny, and in type 1 diabetes anyway, there is going to be like less delivery, there would be like less fat in the body, so we can use the buttocks in the patient as well. So as far as the delivery is concerned, I'll just jot it down. The preferred site is already mentioned. Anterior abdominal wall is the preferred site for delivery of insulin. But over and above this, I said we can also be using the anterolateral aspect of the thigh. We can use the anterolateral aspect of the arm. And in a very thin patient where there is complete loss of subcutaneous tissue, then in a very thin, skinny Indian child, even the buttocks can be used. So these are like the sites, and the sites have to be rotated. I mean, the point is rotate the sites. The rationale behind why should you rotate the sites of insulin administration is primarily because of the side effect of lipodystrophy, or like I can say lipohypertrophy. And that is like one thing that we would like to avoid. Out of the 4 sites, I said preferred site to be answered as anterior abdominal wall, periumbilical, 2 centimeter away from the umbilicus. As far as the methods of delivery are concerned, there would be total of 4 methods. This, guys, is a game changer. CGM, continuous glucose monitor. This continuous glucose monitor will be monitoring. You see, in earlier times, we used to advise patients to purchase a glucometer. Then we used to tell them to go for self-monitoring of blood glucose, which is very cumbersome, because you have to prick the patient. If you have to prick again and again, no person will you always be like, okay, let me postpone it for evening. If I have to check my blood sugar 2 times a day, 3 times per day, because it hurts, no, every time you prick, even if you are using a very thin lancet, which is like, almost painless, still, I mean, the trauma of, pricking yourself is something that nobody wants to endure. So most people used to keep on postponing checking their blood sugar, which is not warranted, not recommended. So the message at the moment is that instead of purchasing a glucometer and then pricking the patient, pricking himself or herself again and again, and monitoring blood sugar is very tedious, very cumbersome. So continuous glucose monitoring can be put on the arm of the patient on the anterior abdominal wall. This small computer will be connected to insulin pump also via Bluetooth, and this computer is now getting a real-time value of blood sugar. And if the blood sugar will begin to spike, then through this catheter, it will be delivering insulin to the patient subcutaneously. So as I explained to you, the preferred method of delivery of insulin, full form I've already written before you, CSII, continuous subcutaneous insulin infusion. But obviously the cost might go up to 1 lakh rupees, and lot of poor people in a country may not be able to afford it. And that is why, I mean, if somebody cannot afford an insulin pump, I have a backup also. The backup I can be recommending in this case is use of an insulin pen. Now, insulin pen can be carried by the child to his school, and he can inject himself with insulin. And when I'm telling this to the mother is like, are you serious, doctor? I mean, do you think that child will inject himself? She says, my child is, all children are. And she says, my child is horribly afraid of needles. and you are telling me that he'll carry a pen to the school, and then you expect, like, even if I adjust the dose and everything for him, do you think that he will be able to inject himself? So we will tell her that, ma'am, nowadays the needles that are available are like very, very thin. This that I'm explaining to you at the moment is like a almost a painless and a bloodless delivery of insulin. That the needle that is present here is like a 32G needle. If you guys in your PSN posting have given BCG vaccine, then the lancet would be like 26G. This is even much more finer and thinner than that. So I said it's almost painless and bloodless delivery of insulin. That would be a 32G needle. And with the insulin pen, the injection is made at an angle of 90 degrees to the skin. I repeat this fact because traditional vaccines which are given subcutaneously, whenever you read, your PSM teacher will be saying subcutaneous vaccine is to be given with help of a needle. Like subcutaneous vaccine is like measles vaccine or MMR vaccine. So it would be given at an angle of like 45 to 60 degrees to the skin. But here I'm telling you to give injection at 90 degrees to the skin. So insulin pen, remember, the injections are given at 90 degrees to the skin, and the size and the depth of the needle is like fairly, I mean, you can easily reach the subcutaneous spot, or you can hit the subcutaneous area with a really small lancet here. So as far as the needle is concerned, the length of these needles will vary. I mean, in earlier times, what I'm writing at the moment, in earlier times, those needles used to be really long. That was up to 12.5 millimeter in length. But nowadays, the needles which are available, the latest ones which are available are like ultra short. And usually the subcutaneous tissue is available about 5 millimeter or to 6 millimeter below. So 4.5, especially for the respect to a child, would be a fairly, I would say, a decent amount of depth required for delivery of insulin. You inject too deep if you hit the muscle. You see, if you're using a very big needle, you hit the muscle, then it will cause a sudden drop in blood sugar of the patient. So I don't want to be intradermal. I don't want to be intramuscular. I want to deliver the insulin subcutaneously. They will not ask you the length of the needle. They will not ask you regarding this 32G needle. This was just to sensitize you to the acceptability component, that if it's gonna be a smallish needle, lengthwise is also small, and it's like very pointed, and it can easily glance through the skin. It can easily navigate through the skin without causing substantial amount of pain. So that's why the compliance of our patients will definitely improve. So we have CSII, we have an insulin pen. But in case a patient is like, or a mother is like totally non receptive to the idea of giving injectable insulin, then no problems. We can give inhaled insulin to the patient as well. You can take name of a brand at the moment, Afreeza. In fact, that's the only brand that is available, and this would be rapid acting insulin. Technically, now in pharmacology, they divide the discussion into short acting and long acting. But I'm just taking the liberty of mentioning a word rapid acting here because it usually will start acting within 30 minutes. So if this inhaled insulin is to be taken, then because the onset of action is as early as within 30 minutes. So like 30 minutes before breakfast, 30 minutes before breakfast, 30 minutes before lunch, 30 minutes before dinner. Not too much of a hassle, no. Just take inhaled insulin and the patient would be doing fine. But obviously, a poor Indian patient will not have the luxury of either being able to afford an inhaled insulin or a insulin pen or an insulin pump. So most of the time, a poor, average, middle class, lower middle class Indian parent would be purchasing a multi-dose vial of insulin along with those 1 ml insulin syringes, and then they'll be injecting the child with insulin, and subsequently the child can be taught to inject himself with insulin. Obviously, calibration initially will be a problem, so you have to be patient, you have to teach them properly, but then lots of time multi-dose vial of insulin is the one that would be used. As far as the storage temperature of insulin is concerned, especially with respect to multi-dose vial, because the vial will be having substantial amount of dose to last up to a month of the patient, so storage is important. So where should it be stored? It should be stored in the door of the refrigerator. The storage temperature would be plus 2 to 8 degrees Celsius, and that is the temperature that is possible only in a refrigerator. Suppose in India, a poor family in Rajasthan where temperature can go up to 50 degrees Celsius does not have a refrigerator in the house. In those circumstances, you can understand that the shelf life of insulin will then reduce. Anyway, opened vial, I mean, if vial is opened, then he says use the vial within 1 month of opening. This is again important because if you keep it at like elevated temperatures, then the potency of the molecule or the potency of the drug will begin to reduce. So he says shelf life is used within 4 weeks of opening. The storage temperature is +2 to +8 degrees Celsius. And I said in some states of India like Rajasthan where temperature might be hitting 50 degrees Celsius. Suppose the family is not having a refrigerator, then you can ask them to purchase a small earthen pot. वो जो मिट्टी का कंटेनर आता है ना, जैसे जो छोटा सा घड़ा सा नहीं होता या मटका होता है, so that matka which is available, that can be basically used to keep the vial of insulin inside, and you can cover that matka with a wet piece of cloth or a small towel. So when the water will evaporate from the towel, that will act like a small portable refrigerator. I mean, after all, those earthen pots are what I'm talking about. Earthen pots are used to keep water cool in India when we did not have electricity and when we did not have refrigerators. So I'm saying that we are just keeping the vial inside that earthen pot, cover it with a wet cloth, and that will cause evaporative losses to happen and will keep the temperature at least to a level where the insulin shelf life can be maintained. As far as the deliveries are concerned, if they ask you to select one, then the preferred site of delivery would be answered as continuous subcutaneous insulin infusion. We have to continuously rotate the sites of insulin so as to reduce the chances of lipoatrophy in a patient. Though there's one more side effect of insulin that I'll talk about in a while, which is obviously hypoglycemia. But before I talk about it, it is also important that I speak regarding basal bolus regimen. What I mean by basal bolus regimen is that when this patient is going to bed at night, then at 10 p.m. in the night, we will be giving insulin to the patient that is long acting. That long acting insulin is what is called as glargine, and this glargine will be working in the body of this patient for the next 24 hours. So this that I've currently marked before you, this red curve will be working for next 24 hours. This is what is technically called as basal insulin. So in the exam, he simply said which type of insulin is used as basal insulin. So the red marking that I've done here before you is for basal insulin, that is glargine. Now, when the patient will wake up in the morning, he or she will obviously take breakfast, so the sugar will rise in the body. If you want that rise of sugar to basically come back to euglycemic levels, you see, in diabetics, the spike of sugar will be very, very pronounced. Postprandial spike is going to be very, very prominent. So if you want that the blood sugar should stabilize, then you need to give insulin injections to the patient like 25 minutes before breakfast, lunch, or dinner. Like if breakfast time is for example 6 a.m., 7 a.m., whatever, like I'm assuming the child has to go to school in the morning, so he'll have a quick snack or quick breakfast in the morning. Like if he's on a Sunday, then it could be at 8 a.m. But the message at the moment is that most of the time the meals would be in India, the meals would be three major meals, like breakfast, lunch, and dinner. So whatever time in the morning the patient is having his breakfast, it could be 6, 7, 8, whatever, 25 minutes before that, a shot of Lispro or Aspart can be given. I'll just write out that in a separate color. Lispro or Aspart are gonna be like short acting insulins, and they start working within 25 minutes. So suppose the patient is having breakfast at 6:30 in the morning, then this injection should be given by like around about 6 o'clock. Or if the lunch time is 1 o'clock in the afternoon, then the injection should be given by 12:30, 12:35, so that it starts working in the body. So this Lispro or Aspart that we are using is what is called as bolus insulin. The learning point for you guys is basal word means that like if you and me are not eating anything, still our pancreas is producing little insulin. So that basal basically is the long acting insulin that we're giving to the patient. And every time before breakfast, before lunch, and before dinner, we are giving a bolus insulin to the patient. The rationale is to bring down the postprandial spike of sugar, because if I don't give this bolus insulin, the moment he will eat that aloo parantha or he will eat whatever food item, then suddenly the sugar in the body will spike, and it is those spikes of sugar that are dangerous. If you want that spike to come back to euglycemic range, if you want that spike to come back to normal, you have to provide insulin from outside, because type 1 diabetes is all about insulinopenia. And as far as the total dose, they'll not give you formulas, but I just want to tell you that whatever dose you have calculated on the basis of body weight of the patient, like suppose the total dose calculated is about 10 units, then the 10 units would be given 50-50. 50 would be given as like a basal insulin, 50% would be given as a bolus insulin. This is like 50% of the total calculated dose based on the body weight would be given to this patient in divided parts. That is the basal part, which would be bedtime insulin. Additional point which I would like to also mention is that as far as glargine is concerned, the dose response curve is very flat, because if you check out the dose response curve for Lispro or Aspart, which is helping in controlling the prandial value of blood sugar, you can see the value is rising and then is coming down. But here the dose response curve is very flat. So therefore, the one-liner MCQ from the pharmacology perspective side, which form of insulin is called as peakless insulin, and your answer would be given as insulin glargine. Having said that, now we will focus on side effects of insulin usage. One of them, as I said already, is lipohypertrophy, but they can be hypoglycemia as well. So it is very important that once the child is given an injection of insulin, then the meal should be provided to the child, because child is not going to eat on their own, and most of the time children are fussy also. So you must explain to the mother, because see, a mother in the kitchen will also be having so many tasks in her house. So you have to tell her, ma'am, that once you give the shot of insulin, ensure that your child starts eating within 30 minutes of administration of insulin. Because suppose she started maybe washing clothes, or maybe she got busy in some other household chores, or maybe she got busy on a phone call if she's a working mother, then in those circumstances the child can land up in hypoglycemia. The cutoff should be remembered as plasma glucose values less than 54. But in some MCQs they will ask you regarding levels of hypoglycemia. So if he says level 1 hypoglycemia is, then the value would be answered as 55 to 70 milligram per deciliter. If he says level 2 hypoglycemia, then would be the critical value that I was mentioning before you, because at this time neuroglycopenia would start setting in, and the patient would start getting edgy. There would be like mood swings, emotional lability that would be coming in, along with sympathomimetic stimulation. And level 3, for level 3, like he says, like it is not any mathematical value. He says any level that results in development of incapacitation of a patient. Now this patient is not in his senses, he's not opening his eyes, and his family members have to literally carry him to the ambulance and then bring him to the hospital. So any level causing incapacitation of a patient, where he will have to seek, where the patient himself cannot seek medical help, and it's like the nearby people or the family members who have to bring him to the hospital, is called as level 3 hypoglycemia. As far as the symptoms of hypoglycemia go, if you have ever gone for an exam without having your breakfast, most of us, we go for an exam without having a breakfast. So we tend to feel a little edgy. It's like initially the adrenaline rush will help us through, because counter-regulatory hormones will be released. Counter-regulatory hormones are like glucagon, cortisol, catecholamine. So they help us initially. But once you've not eaten for a substantial duration of time, you tend to feel a little edgy. So at that point of time, mood swings can occur, emotional ability can occur, attention span of an individual. Like if you're trying to learn a concept and if you're hungry, there would be problems in understanding it. Patient will start feeling angry, or person will start crying without a reason. Person might start fighting with the loved ones over a phone call. And once the blood sugar values become critically low, going towards level 2 and level 3, that's where sympathomimetic stimulation will occur. Because of the sympathomimetic stimulation, you will notice person will start having palpitations, there would be tremors, subsequently sweating will also start, and all this is because of the excessive sympathomimetic drive that will be occurring in this patient, because counter-regulatory hormones are at work, especially catecholamines are at work. At this point of time, however, you will also notice that the person will feel like sleeping. He will say like, I'm feeling a little sleepy, and then when somebody will try to wake him up to give something to the patient to eat, he will not wake up. So drowsiness will occur, and in fact it is now a cause of concern, because at any point of time you could be having neuroglycopenia so severe that person can have seizures also. See that the cutoff is not defined, like less than how much will person have development of seizures. It depends on person to person. Like if somebody has a habit of doing intermittent fasting from a young age, then his body will be able to handle low blood sugar values relatively better. A person who has never fasted in his life, he will start having symptoms at, like I would say, CNS manifestations at as early as maybe 50. Whereas a person who's used to fasting, like maybe a soldier who has been trained to fight a battle without eating for one day, a soldier whose body has got adapted to less availability of food, he will be able to maybe perform at a value of even 40. And a person like you and me, who's like not adapted to fasting at all, at values of 50, 55 also, we might feeling drowsy as well. So there's no critical value below which he has said that there is gonna be possibility of development of seizures. But yeah, yeah, I mean, most of the time, whenever we see seizures due to hypoglycemia, the values are like outrageously low, like 20, 30, something like that are the values that would be coming. Now, at this particular point of time, why I went into hypoglycemia component is just to say one, that if he says, how would you handle a patient who's having symptomatic hypoglycemia? So I will have to secure a IV line, and then I will have to give 25 to 50% dextrose. Obviously, if it is a child, then we will be using 10% dextrose. But the message is that if person is symptomatic, then it is always a good idea to secure a IV line, because once he starts having seizures, then if somebody's body is like shaking uncontrollably, it's like literally very, very difficult for anybody to be able to, anybody to secure an IV line. So first thing is, in any symptomatic hypoglycemic patient where sugar values are going below the cutoff value of less than 54, get an IV line in place, give 25 to 50% dextrose, less neuroglycopenia induced seizures occur. Then he also says that in case a doctor is not able to secure IV line, and that can happen because person suddenly starts having seizures, then you must be ready with a injection of a counter regulatory hormone, that is glucagon. It's 1 milligram subcutaneously that would be given. Glucagon is recommended only in those cases where there is development of hypoglycemic seizures and there is failure to get IV access, because if you can get an IV access, it is perfectly fine. And obviously you can understand here, no role of diazepam, lorazepam, because if I give diazepam, lorazepam, somebody is having hypoglycemic seizure, then I'll be able to like control the seizure for a transitory duration, but then hypoglycemia would not be managed in the patient. So here at this moment, I've tried to explain management for symptomatic hypoglycemia. And like I said, once there is development of seizures in a patient, it is a progressively downhill ride. So ideally we should avoid the person's blood sugar values to deteriorate to such a low level that hypoglycemic seizures will occur. Now comes the role of beta blockers in diabetes mellitus. You can see that beta blockers are gonna mask the symptoms of hypoglycemia. Why I'm saying that is that they will mask the symptoms of hypoglycemia is because one of the sympathomimetic symptoms that I was describing was palpitations and then was tremors. Palpitations is beta 1 and tremors are related to muscles, that is beta 2. So if we are giving beta blockers in a diabetic, then they will mask the symptoms of hypoglycemia. Mainly the symptom that would be masked would be the one that I'm highlighting at the moment, palpitations and tremors. But then, especially from the pharmacological perspective, he will also ask you that beta blockers will mask on the symptoms of hypoglycemia, except then your answer would be given as sweating, because sweating is going to be like cholinergic in drive. So therefore, the diaphoresis component of the sweating component would not be masked. Now, I would like to say a reality check. A reality check would mean that majority of patients of diabetes mellitus would be having triple vessel disease. Because of triple vessel disease, they might already have undergone a coronary artery bypass grafting, or they would be having stents in their coronary arteries. So if a diabetic patient is already having atherosclerotic cardiovascular disease, like he's having stents in his coronary arteries, or he's undergone bypass grafting, or he is a case of chronic stable angina, if there is already blockages in the coronary arteries, then we will give metoprolol to the patient, because metoprolol reduces oxygen consumption of the heart, and one of the drug of choice for chronic stable angina, if you listen to the cardiology component, is metoprolol. Now when I say like this, the query most people is like, sir, on one hand you are saying don't give beta blocker, they mask symptoms of hypoglycemia. On other hand, you say you are giving metoprolol because patient is having chronic stable angina. So what should we answer in the exam? So I resolve this here. You see, from the pharmacological perspective, because when we study pharmacology, then it's like becomes a bit of a myopic view that we are looking at like masking the symptoms of hypoglycemia. He says don't let hypoglycemia karna. Tell the patient to be aware of the fact that insulin causes low blood sugar, so try to eat on time. At least for a child with diabetes mellitus who's on insulin, I'll tell the mother to always carry a candy, chocolate, something with her in her backpack, in the glove compartment of a car. And I'll tell her, if your child starts acting cranky, he rota ja raha, the child is acting cranky, and you don't have access to checking the blood sugar of a patient, just give him a chocolate or a candy, so that at least you don't end up in a hypoglycemic state. And then we have, issues like seizures in a patient. So the message at the moment is, from the pharmacology perspective, it is okay to say beta blockers mask the symptoms of hypoglycemia. But as far as the real world is concerned, as far as the reality is concerned, as far as the clinical practice is concerned, beta blockers are a yes. We give beta blockers to patients of diabetes mellitus with atherosclerotic cardiovascular disease because beta blockers reduce oxygen consumption of the heart. And if there's blockages in the coronary artery, the fuel is in short supply anyway. So I'll repeat my statement: beta blockers are the major mortality reducing drugs in chronic stable angina. That's the question that has been asked in our exam. And then he said, agreed that they're mortality reducing drug. Would you give it to a diabetic? The answer is a yes. And as far as masking the symptoms of hypoglycemia is concerned, I said it's only from the pharmacological discussion. It is only for this except wala MCQ that they discuss about it. But the reality check is that beta blockers are on for any diabetic who's having a concomitant atherosclerotic ASCVD stands for atherosclerotic cardiovascular disease. Next up is Somogai phenomenon, which is characterized by nocturnal hypoglycemia. Now, I have a child of type 1 diabetes ketoacidosis who was successfully discharged from the hospital. After discharge, he has been put on basal bolus regimen, and in that basal bolus insulin, every day at 10 p.m. in the night, this child has to take 10 units of glargine, which is long-acting insulin, and I want to achieve euglycemia as long as the child is sleeping. Because when he will wake up in the morning, when he will have his breakfast, obviously the fluctuations of sugar will occur. But my objective is that when the child is sleeping, the sugar values remains constant in a range of about 150 milligram. That's like a decent value to be obtained in this patient while the child is sleeping. Now, maybe my handwriting was not very good, and because of this, when I wrote 10 units, the zero was looking like a 6. You know, when you write zero and if you don't write it properly, it will look like a 6. So one could be an error on my part that my handwriting was not good, and therefore more than what was required, the dose of insulin was given. Another possibility could be the child was fiddling with that insulin pen, and he just turned the knob, and therefore the dose became set at 16 units. Or another possibility can be mother is having some refraction error and she did not, like, instead of 10 she is giving 16. But what I'm trying to say here is that at 10 p.m. in the night, when the child is going to bed, extra amount of insulin is being given to the patient over and above whatever is required. This is going to contribute to a drop in the blood sugar of this patient. So this is what I'm showing. The graph will now change and the blood sugar of this patient will begin to fall. Because the blood sugar is beginning to fall to hypoglycemic range, let me introduce a very outrageously low value, like let me say 45 milligram per deciliter. That's like really, really low, no? That is less than the threshold of hypoglycemia that I was explaining to you. So now the body will go into a fight back mode, that is counter-regulatory hormones will be released. The counter-regulatory hormones that would be released would be like glucagon, cortisol, catecholamines. Catecholamines are like epinephrine or epinephrine that would be coming from the adrenal medulla. So all these hormones will now start coming in the circulation in excess because they want to follow further decrease in blood sugar value to prevent a neuroglycopenia. And therefore, because thanks to these catecholamines, the blood sugar will once again start rising in this patient. And now the problem is that when the child will wake up in the morning and if you check his blood sugar, it will be turning out to be like 200 milligram. The reason why this sugar is elevated is because of the counter-regulatory hormones that were released in the body of this patient because of nocturnal hypoglycemia component that came in. And why that nocturnal hypoglycemia occurred was because of the fact that extra dose of insulin was given at bedtime to this patient. So as far as Somogai phenomenon is concerned, what the examiner wants to hear is the following statements that I am now writing before you, that at 4 a.m. in the morning, if we check his blood sugar, the blood sugar value is less, obviously because excess insulin is being given to the patient. So therefore, from the MCQ perspective, Somogai phenomenon has a alphabet O present there multiple times. Somogai has a O. So I just want you to remember hypoglycemia is the manifestation at 4 a.m. in the morning. That's why I'm saying nocturnal hypoglycemia. But in the same patient, when I will take the blood sugar value at 7 a.m. in the morning, that I can either say the word pre-breakfast, or instead of writing pre-breakfast, you might write the word early morning. There would be an early morning hyperglycemia in this patient. What you have to understand as a doctor is that because this patient is having an early morning hyperglycemia, one thought process of mine can be that I should increase the morning dose of insulin because this blood sugar value, if it is elevated, then morning dose of insulin needs to be increased. But you can see that even if I increase the morning dose of insulin, that would not be a very wise thing to do, because why is this insulin releasing? Why the sugar value is elevated is because of the counter-regulatory hormone. If I give extra insulin to this patient here, it will neutralize it. No problems with that. But did I counterbalance or did I do anything for the actual problem? The actual problem is blood sugar is decreasing in the night, and I have not done anything for that. So ideally what I should do before I add or increase the dose of insulin in the morning, I should be cross checking what was the dose of insulin given the night before, because here extra amount of insulin was given to this patient, which is contributing to Somogai phenomenon. So ultimately the message here is Somogai has a O present. There is nocturnal hypoglycemia followed by early morning hyperglycemia. Sometimes instead of writing the word early morning, he may even write the word pre-breakfast. I'm not writing it understandable. No? 7 a.m., 8 a.m. is when the people are going to have their breakfast. So pre-breakfast hyperglycemia would be present. The main aspect to be remembered is this fall of blood sugar that is occurring in the night, and followed by this the counter-regulatory hormones are being released to prevent neuroglycopenia, so the sugar will begin to spike. The treatment of this condition is not to increase the morning dose of insulin, but to actually check or adjust what is the dose of insulin given the night before. Now let us compare that with dawn phenomenon. In dawn phenomenon, this is a patient of type 2 diabetes mellitus. His blood sugar at 10 p.m. in the night is like 150 milligram. And since his blood sugar was initially very elevated, or the HbA1c initially was grossly elevated, so the patient is still on insulin. And the insulin that is being given in this case is again long-acting insulin, that is glargine 10 units. The patient has taken the precise exact amount of insulin that I had written, like 10 units had to be given, and patient took 10 units. I emphasize that by erasing it and writing it again, that the precise dose of insulin was taken, and therefore in this patient I expect that the blood sugar while he's sleeping should remain in a euglycemic range of like 150. But the problem is that especially with respect to patients of type 2 diabetes mellitus, where we get dawn phenomenon, the receptors of insulin tend to go on a strike. What I mean by receptors going on a strike is that between 4 a.m. to 7 a.m. in the morning, what happens is that there is down regulation of GLUT4 receptors. GLUT4 would stand for glucose linked uptake receptors 4, which are present on the muscle and the adipose tissue. And because of the down regulation of these GLUT4 receptors, what is going to happen in this patient is that the blood sugar of this patient will now begin to rise. So even in this particular case, in the morning when I will check the blood sugar, it will turn out to be, let me say, 200 milligram, which is obviously, what I did not desire, but that's because the receptors went on a strike. In this particular case, the blood sugar value at 4 a.m. in the morning was like also 150. So if they give you a chart like this, where you notice like 10 p.m. is 150, at 4 a.m. is 150, maybe 150, 160, whatever value is given. But if you notice that the initial two values are almost the same, and then you are getting a spike in the value of sugar, that's because of the receptors going on a strike. In this case, even if I give more amount of insulin at night, it's not going to help the patient because receptors would still be on strike. So here I will have to increase the morning dose of insulin for this particular case. But the point is, dawn phenomenon is because of the down regulation of receptors. Here there is no extra insulin being given to the patient. So here for 4 a.m., the technical word would be that there would still be nocturnal hyperglycemia. The key word is Somogai phenomenon at this point of time was having nocturnal hypoglycemia. Here it is a nocturnal hyperglycemia, in contrast to, I'll just show in Somogai, the sugar values were low, so I said nocturnal hypoglycemia. And as far as the 7 a.m. value is concerned, that can either be written as pre-breakfast or it would be written as early morning hyperglycemia. If you are listening to me carefully, you will notice that early morning hyperglycemia is present in both dawn phenomenon as well as Somogai phenomenon. So obviously he will not ask you what the 7 a.m. thing. He will simply ask you regarding where do you get nocturnal hypo versus nocturnal hyperglycemia. So especially in Somogai, it's a nocturnal hypoglycemia that would be present. Next up, I'm gonna make you brush up your pharmacology. You are aware for the various types of insulin preparations. Pharmacology people will divide the discussion into two parts, that would be short acting and long acting insulin. And among this, the question that came in the paper said, which is the longest acting insulin? Or instead of asking like the longest acting insulin, he can just say ultra long acting insulin. Glargine works for approximately 24 hours. Here I'm saying insulin is working for 42 hours. So that's again a question to be remembered, that longest acting insulin degludec will be working for good 42 hours, ultra long acting insulin. Then we also have NPH, like the traditional ones, detamir and glargine, they work for 24 hours. Then we have NPH. I'll just write down the full form for the sake of completion. You know that from pharmacology. NPH will be working for good 16 hours, that is neutral protamine higdon. And then we also have commercial preparations available where you could be having combinations of NPH with the rapid acting or short acting insulin. We do not have combinations of long acting with short acting insulin because they have a different pH. Like you'll not get combination of glargine with Lispro, but you'll get combinations of Lispro with NPH. I repeat that fact once again. Lispro NPH combinations would be present. Regular and NPH combinations can be present. So short acting insulin can be mixed with like NPH, but not with glargine because of the different pH being present. And then as far as the action of aspart, glulicin, or Lispro is concerned, you can see that they will start acting within 25 minutes. That is why I was saying initially that the child should be given food. Like when I was describing basal bolus regimen, I had remarked the statement that I'll tell the mother that when, ma'am, irrespective of how busy you are, if you're given a shot of insulin to the child should be given something to eat within 30 minutes, because children don't eat by themselves. So child should be given something to eat within 30 minutes of administration of insulin, and therefore they can also be referred as rapid acting insulin. Then as far as regular insulin is concerned, it will work within 30 minutes to 1 hour. Regular insulin is the only form of insulin that can be used both subcutaneously as well as intravenously, and this regular insulin is the one that is usually recommended for emergency usage, like in case of diabetic ketoacidosis, or when I'm dealing with a medical emergency like hyperglycemic hyperosmolar coma. Both DKA and hypersmall coma comparison of blood work is in a separate video in Fairly. So I would like you to listen to that also once you're done with this video. But then regular insulin is the only one which can be given both subcutaneously as well as intravenously. All others are given subcutaneously only. So that is why this table is important, at least for like ideally they can ask you any data. When would it start acting? What will be the total duration? When the peak will be happening? But at least the minimum that I expect out of you is to get the values right, 40 to 24. And then with respect to regular insulin, where the entire data is important, onset would be like 30 minutes to 1 hour, the peak time would be 2 to 3 hours, and then the effective duration would be 4 to 8 hours, which means that it needs to be combined with NPH if I want to give like lesser number of injections per day. You see, some patients will not be ready for that basal bolus regimen where 4 injections in a day have to be given. So they might be like mothers or parents who might be saying that can't you make it 2 injections in a day? So especially when it is 2 injections a day, it is like combinations that would be used. As far as the inhaled insulin is concerned, it is again rapid acting. It starts acting within 30 minutes. And I said in those patients where they don't want to go for any injection, then it is perfectly fine by me. Like if they say categorically, I don't want to take an injection, not a problem. Then in type 1 diabetes, we can give inhaled insulin as well. You can also notice there is no value with respect to peak for degludec, detabir, and glargine, and that is what I was saying initially, that they will have a flat dose response curve. So for these three that I mentioned before you, that is degludec, detabir, and glargine, they would also be referred to as peakless insulin. Now, what are the indications for giving insulin in a patient? So the first and the foremost is highly important. Every time they give you a case of type 2 diabetes mellitus, don't straight away say I will give metformin to the patient, because in type 2 diabetes mellitus, if you notice that at the time of diagnosis, if HbA1c is more than 10%, then we don't start with oral hypoglycemic drugs. It's a separate thing that when you will tell the patient, no, I need to start you on insulin, he says, no, I don't want to take it, start, give me oral medicine. I'll inform him, okay, explain to the patient insulin is required, does not want it. So that's when oral hypoglycemic drugs would be started. The message is in any case of type 2 diabetes mellitus, if you notice that their HbA1c at the time of diagnosis is equal to and more than 10%, they should be guided towards, or they should be like encouraged to start taking insulin to reduce the possibility of complications that can occur because of poor glycemic control. And random plasma glucose values, if they're like, if HbA1c is not given, then random plasma glucose more than 250 in any newly diagnosed case of type 2 diabetes is also an indication for starting them on insulin. Initially, they'll ask you, will I have to take it for whole life? So you will say, okay, initially you take it for a few times so that we can bring down your HbA1c values between 8 to 10%. And once they come down to that range, that is when we can plan for a next consult where we can start you on oral hypoglycemic agents. Then if a diabetic patient is having severe catabolism, by catabolism I mean severe amount of weight loss, both type 1 and type 2 diabetes mellitus can be having weight loss present. Type 2 diabetes can be having in initial phase weight gain also. But subsequently, in all types of diabetes, even type 2 diabetes later has insulinopenia because of beta cell burnout. So ultimately, weight loss, severe catabolism, that's an indication for insulin. A patient ends up in ketosis, ketonemia present, ketonuria present, because ketonemia is dangerous. No, it will stimulate the vomiting center. There would be stimulation of respiratory center, so small breathing will come in. So as far as I can say, 2, 3, and 4 pretty straightforward. Substantial decrease in weight, ketonemia, progression, risk of progression towards ketoacidosis, pregnancy, gestational diabetes mellitus, those are all indications for insulin. Over and above this, if I document that a person is already having diabetic nephropathy, for example, if organ damage is demonstrated, then I should advise the patient to stop taking metformin, because metformin is anyway contraindicated if the estimated GFR of a patient is more than 30 per minute. I've said this earlier also, I'm repeating this once again. Metformin is not to be given if estimated GFR is less than 30 ml per minute, because of the risk of development of lactic acidosis. And in fact, because of the organ damage that is present in this patient, like diabetic nephropathy patient, eGFR is less, we should tell him that we will put you on insulin. Then any patient or diabetes who's basically being scheduled for any kind of surgery, whether it be a major surgery or a minor surgery, it is recommended that they should be put on insulin, get good glycemic control, so that at least the surgeon is not worried about the complications of diabetes mellitus. And anytime that the risk of infection in diabetic patients is anyway higher as compared to ordinary population. The third cutoff is again important. If HbA1c of a patient remains more than 9% in spite of three classes of in spite of three classes of oral hypoglycemic agents, you see, I was trying to draw parallels here with resistant hypertension. In resistant hypertension in cardiology, I have said that if the BP of a patient remains elevated despite three classes of antihypertensive drugs, that is when we call it resistant hypertension. Similarly, today I'm teaching you where person of type 2 diabetes is resistant to oral hypoglycemic drugs, that is HbA1c more than 9% in spite of three oral hypoglycemic agents being used in a patient. That would be like maybe metformin, along with that glipizide is going on, maybe we have given gliptins to the patient along with that also. So in spite of three oral hypoglycemic agent categories, or like the various types of drugs that I'll be discussing before you, three different types being given still, and at a max dose, like we have maxed out the dose of metformin, maxed out the dose of glipizide, maxed out the dose of sitagliptin in the patient, and still the HbA1c is stubbornly more than 9%. That is the time for giving insulin to the patient. Then if you will listen to the diabetes mellitus part 1 video, I have described 1.5 diabetes, which is called as LADA. LADA stands for latent autoimmune diabetes in adults. So in LADA, which is autoimmune, again the beta cells will get destroyed and the C-peptide values in the patient will begin to fall. I have explained in type 1 diabetes, we get insulinopenia, and 1.5 also there is a insulinopenia, and C-peptide values will be also reduced. So in any case of LADA, if C-peptide is less than 0.3, this is again an indication for starting insulin in the patient. The minimum values that I expect you to remember at this moment from the exam perspective would be point number 1 and point number 7, those mathematical value based questions. Remaining is straightforward. No pregnancy, gestational diabetes, perioperative, that even a non-medical can understand. No before operation insulin, doctor is insisting. But then type 2 diabetes at diagnosis with HbA1c more than 10%, it is not OHA, it is insulin. We can downgrade to OHA subsequently. And if it is in spite of three classes of oral hypoglycemic agents being used, the HbA1c is like still more than 9%. That means that beta cells are burnt out. I mean, we are giving insulin secretagogues, we're giving metformin, and still if it's not coming down, that means the beta cell burnout is there. And in those circumstances, like those drugs are not gonna work, whatever be. Even if you increase the dose, you'll only have toxicity. There would be no benefit that would be seen. So that's where insulin needs to be given in type 2 diabetes as well. Now we are at a very critical part of our discussion, because I'm discussing a table from Harrison which is likely to ask, which is with respect to glycemic targets. In fact, the first one was asked in FMG exam. He said, what should be the target HbA1c in any diabetic once the treatment is instituted? Then answer would be that I would like to keep HbA1c less than 7%. I would like to call that as good control of diabetes mellitus. Or if the value is more than 7%, I'll like to say to the patient that this is poor control. Here he also says that if it is an elderly frail patient, some people who are elderly, they will not be able to exercise, so their sugar values will remain on the higher side. I mean, that physical aerobic activity or resistance training may not be possible. Over and above this, I would also like to say that elderly frail patients will be more prone to hypoglycemia. So if he specifies like a 90-year-old man is having osteoporosis and he's bedridden because of maybe a fracture that he had sustained due to a fall, then I will not insist on getting a HbA1c target of 7%. Then it is 8%. But generally, like the FMG exam question was, what should be the glycemic target in any diabetic patient after treatment? Then I said in layman words, good control is defined as HbA1c less than 7%. Over and above this, if he says what should be the fasting value of a patient, then answer would be given as 80 to 130 milligram per deciliter. As far as the postprandial value is concerned, I've explained that to you already that postprandial value is not useful for diagnosis but for monitoring a case of diabetes, and that is what we are doing at the moment. This slide is basically reserved for talking about monitoring of a case of diabetes. Is he responding to your medication? Is he compliant with your medication? Because if he's going to be compliant with insulin, compliant with medication, then the fasting values should be in the range of 80 to 130, and the postprandial value, that's after meal in the house, when we check his blood sugar again after 2 hours, it should be less than 180. Then there's a new concept that is also introduced, that for type 1 and type 2 diabetes mellitus, he says that it is not possible for somebody to have a ideal value to be present 24 or to 24 hours per day. So he says that if a diabetic patient can maintain, both type 1 and type 2 diabetes mellitus patients, if they can maintain their values in a range of between 70 to 180 for more than 70% of the total time in the day. What I mean by more than 70% would be like there are 24 hours in a day. So 70% would be give and take like about 15-16 hours a day. So we are trying to break down the target into more achievable targets, that in every 24-hour days of your life, at least for 15 to 16 hours per day, blood sugar should remain in this range. Because see, if you are eating, and if you are not very particular about what you are eating, and person is going out to a party where he's eating chole bhature and any kind of street food, that the sugar values are bound to spike. But if we can achieve like for the 70% of the time in the entire 24-hour duration that we have, if a person is able to achieve his sugar values between 70 to 180, then we are like in a decent range to reduce the chances of development of micro and macrovascular complication. He also says that for old and frail patients, the target is the same between 70 to 180. But here I will be little, because they cannot exercise, they may not be able to do light aerobic activity also. They may not be able to even do, forget about brisk walking, routine walking also. Maybe he's already had a heart failure. So person is in rehab now because he's gone into chronic congestive heart failure. And in chronic CHF, if ejection fraction is low, then a person would not be able to do daily walking of 1 to 2 kilometer also. Forget about, going to bathroom itself is a Herculean task for this guy. So there I will be less strict, and I will want that these targets to be achieved at least 50% of the time. And in gestational diabetes mellitus, because I want to minimize the macrosomia component, because infant or diabetic mother is a large baby, they can be like malformations in a fetus as well. So 90% of the time I want the values to remain in this range. The message is that now this new concept has come, that is time in range value. I'll just mention this here. Time in range value basically means that if he does not specify anything in a question, he says time in range with respect to type 1 or type 2 diabetes, it means 70% of the 24 hours a day value should remain between the value that I've written, 70 to 180. If he specifies that it is like a old patient, high risk patient, a diabetes mellitus who's very frail, maybe sustained a fracture, already had a heart failure, okay, 50% of the time, 12 hours out of 24 hours. If it is gestational diabetes mellitus, 90% of the 24 hours in a day, I want these values to be obtained. So the main crux of the discussion is these percentages that I mentioned before you. I'll mention the percentages once again. Values, they are less likely to be asked. These two values or these values are less likely. What they've asked already in the exam is this. That was FMG exam. And what they can ask you future in both FMG and NEET PG is that for how much percentage of the 24 hours duration should the value remain in the range of 70 to 180. This value will be given by the examiner himself. He will ask you the percentage. So we do a quick recap. Type 1 or type 2 diabetes mellitus, uniform 70%. Old or frail person 50% of the time. But if it is gestational diabetes mellitus, 90% of the time, because I want to reduce the impact on the baby as well. Next, we'll talk about management of type 2 diabetes mellitus, where the first thing is medical nutritional therapy. By medical nutritional therapy, I mean that we will have to ensure weight loss in this patient. And this is one of the very highly effective ways to bring down the HbA1c values of the patient by a huge 1 to 3%. I repeat my statement, drugs will obviously work, like metformin can cause up to 2 percentage point decrease in HbA1c, but medical nutrition therapy basically means first and foremost hypocaloric diet. Hypocaloric diet would mean that at least a dietary deficit of 500 kilocalories per day should be obtained, and this would help in achieving euglycemic targets in this diabetic patient. It is obviously difficult because when you cut down on calories, you tend to have that binge to eat. But once the patient, by his willpower, is able to achieve that, then the results are gonna be very, very gratifying. You will have like lot of these non-medical influencers on YouTube or on social media or on Instagram telling people to stop taking milk and stop eating rice and chapati and roti, and like they are saying it without any scientific evidence. But actually, because you and me would not have time to make all those videos for these people in layman terms. So I mean, these non-medical influencers are flourishing, but actually what is required is not that they have to stop taking dal and roti and everything, because that's staple Indian diet. You just have to tell them cut down on the portion. You eat two chapatis at dinner, you eat one and a half. You eat four chapatis, try to eat three. So just cut down on the portion size. Hypercaloric diet is what is required. This single one intervention is the most important intervention as far as preventing the progression of diabetes or reducing the complications in diabetes is concerned. Over and above this, the additional thing is obviously that he should be eating carbohydrates, but those low glycemic index carbs should be consumed. By low glycemic index carbs, I mean like he can be taking oats. Oats, like the blood sugar will not rise exponentially, just like wheat and rice. They cause a very substantial rise. So instead of like white rice, he can be using brown rice. Instead of using plain atta, he can be using multigrain atta. If he's eating eggs, we'll tell him, okay, take mainly the white component, try to take proteins. And what he needs to cut down is basically on zero. It should be zero trans fats. I mean, all those chole bhature and chow mein and all those things, they are the ones which have to be cut down. So it's zero trans fats, low glycemic index carbs, and hypocaloric diet, with the most important being hypocaloric diet. That plays a very important role in causing a lowering of HbA1c, and along with that, exercise would also help. As far as exercise is concerned, when you will ask the patient to exercise, no, he will say, should I buy a platinum membership of a gym, or like should I buy a gold membership of a gym? So you will tell him no need of any one of that. You won't be able to work out in a gym because they're muscle wasting. You would tell him buy some walking shoes and then walk for like 30 minutes every single day for 5 days per week. We are giving approximately 2 days of rest also. So that is like approximately 150 minutes of light aerobic activity. That is like what I mean by light aerobic activity. One is brisk walking, or instead of brisk walking, if we can do like salsa or all those dances which are available, so resistance training if possible. This would help him build muscle strength also, and would help him stabilize his blood sugar also. And my patient, being educated, is asking me, doctor, how is all this working? I mean, how will exercise help in bringing down my blood sugar values? Obviously he's saying, I understand muscles will consume sugar, sir, but you told me that insulin is less in my body in type 1 diabetes. Type 2, later also the insulin becomes lesser. So then how will sugar go inside the muscle? So you'll tell him that there is a receptor on the muscle by the name of GLUT4, and studies have shown that brisk walking upgrades the level of GLUT4 in the muscle, and this promotes sugar entry into the muscle, and this would help in especially managing those borderline cases of diabetes who are like not interested in taking medicine at the moment. Their HbA1c is like 8.5 going up to 9. You are planning to start oral hypoglycemic drugs, but then he's very resistant regarding taking drugs. So you will tell him, okay, if you follow these two aspects that I've told you, that is medical nutrition therapy with respect to the 3 points that I said, and light aerobic activity, this is going to help him in bringing down his HbA1c levels to something in the range of about 7%. As far as exercise is concerned, I said GLUT4 activity would be, or GLUT4 receptors on the muscle are upgraded. They promote entry of sugar into the muscle. And as far as the intensity of exercise is concerned, we will not advise them to do any vigorous activity, because majority of type 2 diabetes mellitus patients can be having atherosclerotic plaques in their coronary arteries, and they can rupture and they can have a heart attack also. So when it was type 1 diabetes, it was vigorous activity, 60 minutes per day. But here it is like mild to moderate activity. I would like to put it on record here. It is not moderate to vigorous physical activity, it is mild to moderate activity because they are having atherosclerotic plaques in the coronary artery. I don't want to take the risk of myocardial infarction. Then, as far as the drugs are concerned, it's a revision from pharmacology. We'll be using biguanides in this patient. The main biguanide that is used is metformin. Fenformin has been banned for a very long time because of the side effect of lactic acidosis, but it's metformin that is used. Now he will ask you, how will metformin work? So there are two mechanisms of action. One is that it inhibits hepatic gluconeogenesis. You know that our liver keeps on synthesizing different products from it keeps on synthesizing sugar from various products. So we are trying to put the brakes on that, inhibiting hepatic gluconeogenesis. The second mechanism of action is it will increase the peripheral utilization of sugar. What I mean by peripheral utilization is utilization of sugar by the muscles as well as adipose tissue. I mean, even adipose tissue, where does it get energy from? It is like from the sugar only. So peripheral utilization of sugar in adipose tissue and fat and muscles would be increased by taking metformin. As far as the efficacy of lowering is concerned, it's a good 1 to 2% decrease if a person will take medicines regularly over next 6 months. Then like the maximum dose of metformin that we can give is about 2 grams per day. So if you're giving like 850 milligram tablet even 3 times per day, you would be like a little above the scheduled range. So it could be like 850 and a 500 milligram tablet, so that you remain in a decent range. As far as the contraindications of metformin are concerned, one of them is that the KFT of the patient is deranged. Do not give this medicine, metformin, to any diabetic who's already gone into diabetic nephropathy. This medicine is absolutely contraindicated if estimated GFR is less than 30 ml per minute. In fact, it has happened that reputed practitioners have had their court cases against them by patient because they continued to give metformin to the patient, though his GFR was lesser, and the patient then landed up in lactic acidosis. I mean, you see, I was saying initially fenformin is withdrawn from the market because it caused lactic acidosis directly, even with normal GFR. But with metformin, what you need to remember is if eGFR is less than 30 ml per minute and metformin is continued, then it can trigger lactic acidosis type B to be developing in a patient. And this is what I have described in my subsequent video as well, when I've compared diabetic ketoacidosis with lactic acidosis. Now, coming to the side effects of metformin, they would be like nausea, vomiting, metallic taste, unexplained diarrhea. This was asked in the INICET exam. And then is lactic acidosis if the estimated GFR is less than 30 ml per minute, already explained to you. And then one that must not be forgotten is metformin can also contribute to vitamin B12 deficiency, because there's so many causes of B12 deficiency. In fact, the most common cause of B12 deficiency is pernicious anemia, but over and above this, even metformin contributes to this. And then if a person of type 2 diabetes mellitus is on metformin and he's being scheduled for coronary angiography, we need to stop metformin. So the couple of indications for stopping metformin as well. One of them, the most important one that must never be forgotten, is any patient of diabetes type 2, when he is being scheduled for a radiographic contrast study like a coronary angiography, then metformin must be stopped in advance. In any patient of type 2 diabetes, once he is hospitalized, that hospitalization may not be for a diabetes related complication. It may be that he is being scheduled for any kind of surgery and the patient would be put nil per orally. The moment the patient is put nil per orally, that means that obviously, like if he's scheduled for surgery, I cannot give him metformin and then operate, because if he has consumed a little bit of water and that if he vomits at the time of induction of anesthesia, everything will go in the lungs of this patient. So any diabetic patient type 2 is nil per orally for any surgical indication, well, we need to stop metformin. Then is obviously if he is obtunded because of metabolic acidosis, that's where you have to treat by giving insulin drip for the person. Any patient who's having liver damage and any patient who's having decompensated congestive heart failure. By CHFD, I mean it's a decompensated CHF. Once he will come out of decompensated state and once you will ensure that he comes out of the ward, then I'll regain and I can restart him on metformin and discontinue insulin. But like these are situations which I can say vice versa, or like when I will stop metformin and put them on insulin. But instead of saying like when would you start insulin in a patient on an emergency basis with respect to type 2, earlier I was saying like insulin to be given in type 2 on a long term basis. But here it is like he's on metformin, he's stable, but then if he's being scheduled for any surgery or is gone into decompensated heart failure or he's being scheduled for a chronic he's being scheduled for a coronary angiography because he had an episode of chronic stable angina, chest pain on walking fast, that is when metformin needs to be stopped. The next molecule that should be started after metformin is GLP-1 receptor agonist. You see, in earlier editions of the app or in earlier editions in the book, you used to read along with metformin, we used to give sulfonylureas to the patient. But now the update is we don't give sulfonylureas, we give GLP-1 receptor agonists because they've been shown to reduce cardiovascular mortality. In fact, that's the opening line of mine with respect to diabetes mellitus part 1 video, where I've said that an update is that along with metformin, the second drug to be started is GLP-1 receptor agonist, that is glucagon-like peptide receptor agonist. And the mechanism of action is that this is going to contribute to increase in the level of insulin, obviously, because it's an insulin secretagogue. But along with this molecule will also decrease the levels of glucagon, because in diabetes mellitus, we find that not only do we have a problem with respect to beta cells, but we also have a problem with respect to alpha cells, that they tend to produce more glucagon, and more glucagon contributes to even hyperglycemia. So if I can decrease the value of glucagon, increase the value of insulin, that's like an insulin secretagogue, then it will help me in controlling the blood sugar very well. Then there's an additional advantage that we found, that it delays gastric emptying with an early satiety, and because of this the person will start eating lesser than normal. This will promote weight loss, and that is the reason why like semaglutide is a rage, especially in America, where like in type 2 diabetes there's a concomitant obesity also, and it's an anti-obesity drug without diabetes mellitus as well. The biggest advantage of this molecule was that it not only contributes to better control of diabetes, it not only helps in weight loss, because weight loss will also reduce the insulin resistance component, but one of the most important findings, I would say, of recent couple of years has been that GLP-1 receptors agonists have been shown to reduce cardiovascular mortality. The drugs that we have available are like exenatide, liraglutide, lixisenatide, and then obviously semaglutide. There are multiple brand names for it, Ozempic being one of them. So like you will notice like literally black marketing of these drugs happening, and they're being sold without any prescription, because people in India just want to lose weight and they just want to look good. But then there is a black box warning that can be asked at the moment also, and this black box warning simply states that there is increased risk of medullary cancer of thyroid. Whenever you study topic of cancer of thyroid, topics are like papillary cancer, follicular cancer, and then comes medullary cancer, where we have that acal amyloid deposition, and calcitonin is the tumor marker. So studies have shown that this drug can increase the risk of medullary cancer of thyroid in rodents. So as a result of it, this molecule is absolutely contraindicated in those patients who are having multiple endocrine, family history of multiple endocrine neoplasia. If there's any family history of thyroid cancer, if there is any family history with respect to MEN syndrome, there are various types of multiple endocrine neoplasias. The one which are associated with medullary carcinoma thyroid is MEN2, that is also called as Sippel syndrome. So at this moment, I just want to bring to your attention that, and this was itself a question, that which medicine increases the risk of medullary carcinoma thyroid in rodents, and the black box warning is present over the medicine, then the answer is GLP-1 receptor agonist. So like every cloud has a silver lining, that is the bad news, but the good news is it reduces CV mortality, it decreases weight, it promotes weight loss, and that is the reason why I can say that it is a rage nowadays as one of the prominent anti-obesity drugs. Please do not answer metformin as a weight losing drug. I would like to mention what American Diabetes Association says with respect to metformin. He says metformin is a weight neutral drug. It may look a little surprising to you if you're reading this for the first time, because traditionally the teaching everywhere has been in earlier years that metformin promotes weight loss, but that is not the case. It's a weight neutral drug, and rather the one that will help in losing weight would be GLP-1 receptor agonist. The next category that we'll talk about is called as DPP-4 inhibitor. The full form of this would be dipeptidyl peptidase 4 inhibitor. Now let us understand how it will be working, and there are like three very commonly prescribed ones that you would have seen on prescription of lot of physicians, that is sitagliptin, saxagliptin, and linagliptin. The mechanism of action is that they will inhibit the degradation of native GLP-1. This native GLP-1 is produced by our ileum. You see, normally our ileum is always famous for like B12 absorption, but what I'm teaching you is that our ileum is having special cells which are called as L cells, which produce GLP-1, and because you are inhibiting the breakdown of GLP-1, therefore the insulin level will rise. So in fact, I can say our objective is to upgrade the output of insulin from the beta cells of pancreas before before they start exhibiting beta cell exhaustion, because in type 2 diabetes later on, once there is a beta cell exhaustion, then these drugs will stop working and finally you will have to start insulin in the patient. So in type 2 diabetes also, in the later stages we give insulin, but initially as long as the beta cells can function, we are gonna use different methodologies by which we are gonna upgrade the insulin levels. And there are three drugs which are available at the moment, that is sitagliptin, saxagliptin and linagliptin. Linagliptin begins with the alphabet L, and therefore what I want you to remember is that it is metabolized by the liver. And this was again a question in the exam. He said which anti-diabetic drug is not metabolized by the kidney, because sitagliptin and saxagliptin are metabolized by the kidney, but linagliptin is metabolized by the liver. So in case like if there is a diabetic nephropathy component present, then we will not prescribe. If we are giving DPP-4 inhibitor and patient is like having diabetic nephropathy, then sitagliptin, saxagliptin cannot be given, but linagliptin can be given to the patient. One more medicine that I would like to mention at the moment, though this is a sulfonylurea, but from the MCQ perspective, I want you to remember that this drug is metabolized by the liver. So from the pharmacological perspective, at the moment, what I want you to remember is there are two anti-diabetic drugs which are metabolized by the liver that you are remembering at the moment. Linagliptin has a L present, glipizide has a L present. Two anti-diabetic drugs metabolized by the liver are linagliptin and glipizide. And the mechanism of action of DPP-4 inhibitors is that they're inhibiting the degradation of endogenous GLP-1, which will further cause an increase in the levels of insulin. The side effects can be angioedema and Stevens-Johnson syndrome. The next category I'll talk about is insulin secretagogues. The mechanism of action will be that they'll act on ATP sensitive potassium channels and will inhibit these potassium channels, by which there would be depolarization of beta cells, and depolarization of beta cells will then contribute to increase in the levels of insulin, and this increased level of insulin will then overcome the resistance of the insulin receptors, which are exhibiting a partial resistance. At this moment, I think you would have recognized the category that I'm talking about, which would be called as sulfonylureas. They are also written as insulin secretagogues, and the drugs are the ones which are like one of the very commonly prescribed ones along with metformin even today. That is glipizide. Because see, the newer drugs that I was talking about, like semaglutide, one tablet would be 300 rupees. So people will not be able to afford that medicine, which is why you will still see patients of yours who might be like on glipizide or would be taking glimepiride or gliclazide or glyburide. These are like I would say favorite of our patients, because they need to be taken once per day. The only disadvantage is that because they will cause a sudden burst of insulin by depolarization of beta cells, so hypoglycemic attacks can occur, or they can contribute to development of weight gain as well. I mentioned the names of the drugs. Glipizide is the one which is metabolized by the liver. And over and above this, I would like to say just the fact that when it comes to GLP-1 receptor agonist, that is semaglutide, this was initially available as like once a week injection, which was very revolutionary in the field of diabetes. Because see, whenever we read about diabetes, the drugs have to be taken multiple times per day, but semaglutide was like once a week injection. Now we obviously have oral tablets which need to be taken on a daily basis. They reduce cardiovascular mortality, that is okay, but then as I explained to you, the cost factor comes in, whereas when it comes to the drugs that I'm mentioning at the moment, the cost factor will dramatically go down. The next category that I'll discuss before you is called as meglitide. They are also insulin secretagogues but are not sulfonylureas. Well, what is the difference between the two? I think you would be aware of this from the pharmacological perspective, that sulfonylureas are long acting, whereas meglitide are also insulin secretagogues, but they act for relatively a shorter duration. So two drugs that I mentioned at the moment before you, these drugs will also act by increasing, they will also cause depolarization of beta cells and will increase the level of insulin, and higher level of insulin will overcome the partial resistance of the receptors. But like why they are being mentioned separately is because their duration of action is shorter as compared to the previous category that I was speaking about. The next category I'll talk about is thiazolidons, and well, how do these drugs work is by decreasing the insulin resistance. Like earlier I was mentioning regarding increasing the amount of insulin in the body by depolarization of the beta cells, either with respect to sulfonylureas or meglitide category, but this time we are downgrading the insulin resistance by binding to PPAR, that is peroxisomal proliferator activator gamma. Now, why this question on this drug category is asked is mainly with respect to contraindications, that this drug would be contraindicated if there's a liver failure, or especially with respect to heart failure, because earlier I was teaching you drugs that cause improvement or reduction in cardiovascular mortality, but here the question will say which anti-diabetic drug can worsen cardiovascular mortality. So especially in a person of diabetes mellitus, if he's already had atherosclerotic cardiovascular disease and is gone into heart failure, then this category needs to be stopped because it has been shown to worsen cardiovascular mortality. This can also contribute to worsening of the macular edema if it is pre-existing in a patient. It can induce ovulation in a patient of PCOD. Well, if a PCOD patient wants to conceive, then it's a good news. But if suppose they don't want to have a baby and the patient is having insulin resistance, then thiazolidinolons can actually induce ovulation and can result in a pregnancy being, the lady can have a pregnancy subsequently, though she did not want to have one. One of another reasons why this drug category will be asked to use because of the increased risk of bladder cancer. Though I'm writing plus minus after it, still like some studies have actually initially shown that pioglitazone and rosiglitazone contributing to development of bladder cancer. Initially, this was like, this drug was banned from the market because of the study that came, and then subsequently, like it was proved that this study had a flaw where it was pioglitazone was attributed to contributing to bladder cancer. But that's why I've written plus minus after it with respect to the fact that initially the medicine was withdrawn, but then it was reintroduced in the market subsequently, but is not to be given to those patients who are gonna be having congestive heart failure. Well, as they say, all clouds have a silver lining. No, if you are having dark cloud, it's like bad news. No, the sky is all overcast, but then a cloud has a silver lining. The good news is studies have shown that these drugs can be causing a reduction in stroke occurrence. So if a diabetic patient type, this I mentioned in diabetes, this I mentioned especially with respect to stroke management as well, that if somebody already has had a stroke and is a diabetic, then for secondary prevention, when I say stroke recurrence, I mean for secondary prevention, already a diabetic patient has had a stroke. So this category has been shown to reduce the recurrence or development of stroke in a patient. The next category I'll discuss before you is one of the most frequently asked in the exam, that is SGLT2 inhibitor. The mechanism of action is it will act via the proximal converted tubule and it will promote urinary loss of sugar. You see, in a diabetic, blood sugar is more, so loss of sugar in the urine is advantageous to me. The advantage that we found over and above this was that it will also cause loss of salt, which will cause a decrease in systolic blood pressure, and therefore the cardiovascular mortality in the patient will also be reducing. So as far as MCQs are concerned, you are aware of the fact that SGLT2 inhibitors will turn out to be cardioprotective. In fact, this is what I said in the initial part of the discussion. GLP-1 receptor agonists and SGLT2 inhibitors are two cardioprotective molecules. Over and above this drug has also been shown to reduce the progression of CKD, and as a result of it, whenever you read about diabetic nephropathy, then there are a total of 3 drugs that reduce the progression of diabetic nephropathy. 2 I will say at the moment, and the third one will be introduced subsequently. ACE inhibitors and SGLT2 inhibitors are on almost every prescription whenever we are trying to reduce the progression of chronic kidney disease. Then we should not be using these drugs if the estimated GFR of the patient is in a range of less than 30 to 45 ml per minute. You see, earlier the guidelines were 45, then they decreased to 30. Now there are trials going on with empagliflozin where they are using it even when the eGFR is as low as 20, but that's a clinical trial. So I would like you to remember a range of 30 to 45. For metformin, it's well defined, like less than 30, don't use metformin, risk of lactic acidosis. Here it's a range of 30 to 45. Common drugs are like empagliflozin, canagliflozin, dapagliflozin are the common ones that are used. Then a disadvantage of these drugs is that they can increase the risk of UTI, that is urinary tract infection, and over and above the risk of UTI, even genital infection risk can also be increased. As far as UTI risk is concerned, some books are saying that you can counterbalance that with increased water intake. But then in some cases, it becomes very troublesome and you might have to discontinue also. When I say mycotic genital infection, I mean like vulvovaginitis in a patient. So this is like a disadvantage that over the advantageous things I was saying. The advantages cardioprotective, renoprotective, and the disadvantage part is the UTI component of the mycotic genital infections. Next is alpha glucosidase inhibitors. Well, the reason why this will be asked to use because this is one drug category that is to be taken with meals. You see, you're aware of the fact that all anti-diabetic drugs should be taken before meal, but this is to be taken with the meal in the patient. That is because this will act by a peculiar method of inhibiting the absorption of sugar via the GI tract. The drugs which are available here are by the name of acarbose or voglibose or miglitol. And as I said, the main mechanism of action is inhibiting the GI absorption of sugar. So patient will be very happy. Like he'll say, now I can eat gulab jamun, I can eat chocolate also. So I will tell him that yes, this molecule will inhibit the gastrointestinal absorption of sugar. But if you club it with a gulab jamun and the sugar will not be absorbed, then it will result in diarrhea. So therefore, osmotic diarrhea is the dose limiting side effect of this molecule. As far as the ability of this molecule to lower HbA1c is concerned, it is about 0.5%. So my educated patient is asking me also, sir, it is calling only 0.5% fall in the value of HbA1c. So why are you prescribing this drug for me when you know that it is not so effective? Well, I'll tell him this drug is not for long-term control. It is for preventing the postprandial spike of sugar. When you eat, the spike of sugar occurs. So if this drug is taken with meal, we keep it on the dining table. You first eat a morsel of food, then you eat the antidiabetic medicine so that it can inhibit the absorption of sugar from the gut. This is again very peculiar because all antidiabetic drugs need to be taken before the meal. Now we'll focus on mechanism of action of the common drugs. Though I've already done this activity, a quick recap here. You see, biguanides, they have two action. One action is that they are inhibiting hepatic gluconeogenesis, and by this they would be decreasing the amount of production of sugar by the liver, plus is improvement of peripheral utilization of sugar. The fall of HbA1c will be up to 2%. As far as alpha glucosidase inhibitor is concerned, the fall is in the range of about 0.5%, but it is by inhibition of the absorption of sugar from the intestine. Because of this particular action, that medicine needs to be taken, it has to be taken with the meals. Then dipeptidase peptidase 4 inhibitors, that was molecules like sitagliptin, etc. They were inhibiting the degradation of GLP-1. And I said this was an endogenous GLP-1 which was being produced by the L cells of the ileum. Then as far as secretagogues are concerned, they will cause depolarization of the beta cells and they will upgrade the production of insulin. And if you upgrade the production of insulin, then you can overcome the partial resistance in the receptors. When it comes to SGLT2 inhibitors, the main reason was that it will promote urinary loss of sugar. Along with urinary loss of sugar, even salt was a welcome additional aspect because of which the cardiovascular mortality of the patient was being reduced. And then thiazolidons, like I would say molecules, they were working in a different way, that they were decreasing insulin resistance. And well, how were they decreasing that insulin resistance? Was by activating that PPAR gamma. So therefore, as far as pioglitazone and rosiglitazone are concerned, they were initially banned from the market because of the false report of aspect of bladder cancer. But then the bad news with respect to them was the congestive heart failure aspect. I mean, they are like the MCQ will say opposite. Earlier I was saying which drugs are cardioprotective, GLP-1 receptor agonist and SGLT2 inhibitor, but he'll say which can worsen CV mortality, especially if it's already gone into heart failure, then it is thiazolidons. The advantage of these drugs, however, has been shown to be that they have been shown to prevent recurrence of stroke. So secondary prevention of stroke is what I mentioned. And then comes GLP-1 receptor agonist anyway. I mean, they will increase the level of insulin in the blood and they will decrease the level of glucagon. And by introducing a balance here, you can achieve euglycemia. The HbA1c lowering capacity is only up to 1% only, but then the advantage of these is they stabilize the atherosclerotic plaque, and especially by stabilizing the atherosclerotic plaque, the cardiovascular mortality component will reduce significantly. Now, which anti-diabetic drug can be used in both type 1 diabetes as well as in type 2 diabetes is the one that I'm mentioning at the moment, pramlintide. The question in the exam said which anti-diabetic drug can be used. Obviously, insulin was not in the options. Insulin can be given in type 1 also, type 2 also when there is a beta cell exhaustion, but in the options, like there was no insulin. So one that is used in both type 1 and type 2 diabetes should be answered as amylin agonists. How this drug will work is it will reduce the intestinal motility, it will reduce the stomach motility. So the contents of the stomach will enter into the GI tract slowly. So therefore the postprandial spike will be substantially reduced. And you can see with medical nutritional therapy and physical activity, you can have as much as a 3% decrease in the value of HbA1c. That is why lifestyle modification is the first step to be done in any patient with type 2 diabetes mellitus, provided he says that in type 2 diabetes mellitus, at presentation, HbA1c of the patient is between 8 to 10%. If he wants to play a game in the MCQ, he will simply say HbA1c more than 10%, and then your answer will become insulin to be introduced initially. Patients of diabetes can also be having increased cholesterol as well as triglycerides. So there are two aspects which I want you to remember. One is primary prevention, second is secondary prevention. Like already had a heart attack, already had atherosclerotic cardiovascular disease, so had to undergo stenting or has undergone bypass grafting, that would be secondary prevention. So as far as primary prevention is concerned, for patients between 40 to 75 years of age, if there is no cardiovascular risk factor, then he says that what you need to give in these patients would be a moderate intensity statin. But when it comes to at least one cardiovascular risk factor present in a patient, what I mean by one cardiovascular risk factor can be like he's having family history of premature coronary artery disease, or he's having smoking as a risk factor, type A personality, hypertension present. If cardiovascular risk factor is present, then we will be starting the patient on high intensity statin. If cardiovascular risk factors are not present, then it is a moderate intensity statin, and the target values will change here. If he says that a person between 40 to 75 years of age has no cardiovascular risk factor on moderate intensity, my target LDL should be kept at less than 100 milligram. But if he specifies that person is having one atherosclerotic cardiovascular risk factor, it could be type A personality, premature CAD, smoking, hypertension, then the target that I want to achieve here would be less than 70. But if he says that he's already had a heart attack, already had like blockages in his artery, he had to undergo stenting, then the target in this particular case would be kept as less than 55. So be careful in the MCQ, especially with respect to secondary prevention. The target is not 70, the target is less than 55. Now, as far as the choice of drugs is concerned, if the person is having LDL being normal and triglycerides alone is elevated, then the drug which is to be introduced is fenofibrate. This you know even from your pharmacology as well, that statins and fenofibrate should not be combined ideally, and it is only when triglycerides are going more than 500, risk of acute pancreatitis is there, that fenofibrate would be started. If both LDL and triglycerides are elevated and the value of triglyceride is not given to be more than 500, mark my words, they're not more than 500, it is like LDL and triglycerides both elevated, and he says what would you like to give to the patient, then it is atorvastatin or rosuvastatin that can be given to the patient. It would be moderate to high intensity depending upon presence or absence of risk factor. Most MCQs will have a risk factor, so you will say a high intensity statin to be given. The third aspect that he can ask you is that if LDL is elevated in spite of giving high intensity statin to the patient, like for secondary prevention, target of 55 is not being obtained, or for primary prevention, the target with high intensity statin of 70 is not being obtained, then what is the next drug to be added in the patient? Then the answer, and this was asked in INISET exam, should be given as ezetimibe. Now, if he says in spite of using both of them, that is high intensity statin plus ezetimibe, in spite of this, we are not having an improvement, then what we will do in the patient will be that we will be adding PCSK9 inhibitors. These would be monoclonal antibodies. Let us now study how these PCSK9 inhibitors would be working. Well, you see, this PCSK9 is an enzyme which is encoded on chromosome number 1, and it plays a role in regulation or turnover of LDL receptors. So when you give these monoclonal antibodies, the inhibition of this will result in more LDL receptors being available for degradation of LDL, and that is what I want. I want to downgrade the value of LDL in the patient. So I have monoclonal antibodies available, that is alirocumab, or it is evolocumab or inclisiran. These are three molecules. I'll mention the names once again: alirocumab, evolocumab, and then inclisiran are the three molecules which are PCSK9 monoclonal antibodies that would help me bring down in those cases where in spite of high intensity statin as well as with ezetimibe, the values of 55 or 70 with respect to primary and secondary prevention is not being obtained. A large chunk of my patients who are having delayed lipid profile would also be having non-alcoholic fatty liver. The definition of fatty liver would be that more than 5% of the total hepatocytes are having a fatty infiltration, and in the same patient who's having fatty infiltration in future, there would also be inflammatory damage present. And if there is an inflammatory damage present, then the technical term that would be used would be called as NASH, that is non-alcoholic steatotic hepatitis. You see, you just have to follow English here. Initially, I was saying that there is fatty liver because more than 5% of the hepatocytes are having fat deposition. Now, if you read the term NASH, steatosis means fat deposition, but there's a next thing that is happening, that is hepatitis component is also coming in. So we call it NASH, that is non-alcoholic steatotic hepatitis. It is an upgrade over fatty liver. The terms are at the moment NAFLD, non-alcoholic fatty liver disease, that is an upgrade to NASH. At this moment, there is no fibrosis in a patient or cirrhosis, but a large number of these patients without intervention will progress to cirrhosis, go into end stage renal disease, and might have a requirement of liver transplantation as well. In fact, in the liver section, I've explained one of the number one cause of liver transplantation now in India and America is non-alcoholic fatty liver. It's not alcoholic liver disease, guys. It's non-alcoholic fatty liver disease. Lots of them are pre-diabetic or diabetics. Now, what test can I be doing to evaluate for presence of non-alcoholic steatotic hepatitis? Then I have a score by the name of FIB4 that I've discussed in the liver section also, but I'll mention the four parameters. That would be age, SGOT, SGPT, obviously because liver is getting involved. And additional one is not prothrombin time, it is platelet count. Traditionally, in all liver scores, we have a prothrombin time present, but here it is platelet count. So age, SGOT, SGPT, platelet count is a mathematical test on basis of which the prediction for fatty liver can be present. Though obviously, the more accurate way for diagnosis would be fibroscan, or would also be called as elastography, which is the investigation of choice. There is no treatment, there is no drug of choice for this condition. He says for fatty liver in a diabetic or even in a not diabetic, it is diet control and weight loss. Only up to 10% of weight loss if achieved in an individual, about 7 to 10% of weight loss if it is achieved in an individual, that the fatty liver in a patient can exhibit a regression also. So I'm putting an arrow in reverse. That is the good news, that some patients of NASH can reverse back. I mean, they can reverse back this hepatitis part. No, one is not only fat and then is fatty plus hepatitis. So this part can reverse back to only fatty liver as well. And can fatty liver ever go back to normal? Well, that is a bone of contention. That's always a controversy. But at least we do find that if aggressive diet control weight loss happens in some patients, you can have a reversal or you can have an improvement as well. Some books have mentioned pioglitazone, or some studies have shown regarding role of pioglitazone, but that is still an experimental approach at the moment. Then one of the long-term complications of diabetes mellitus is diabetic retinopathy. I've already explained to you that there is increased, about 25 times increased risk of blindness in a diabetic patient as compared to a non-diabetic patient. And the problem would be a fundus finding. The earliest fundus finding, however, that would be present is development of microaneurysms. Like diabetes D causes microaneurysm and damages the blood vessels of the retina. Then is also asked, like, these microaneurysms would be developing in which layer of the retina. Like there are total of 10 layers. So what you need to do is a bit of cramming to be done. This would be microaneurysms in the inner nuclear layer. Like in the actual exam, the options were inner nuclear, outer nuclear, inner plexiform, outer plexiform. So this kind of question can only be solved if somebody has read the data in advance, that is microaneurysm formation with respect to the inner nuclear layer. Now, subsequently, in these patients, you would be having non-proliferative retinopathy that would contribute to macular edema. And if he says proliferative retinopathy, then proliferative retinopathy would imply that there is formation of new blood vessels. That would be new vascularization. And because of this new vascularization, if these blood vessels will rupture, then they can be vitreous hemorrhage or they can be a retinal detachment as well, which can contribute to development of blindness in these patients. See, when you attempt those questions, you have to be a little careful. Is he asking you regarding visual loss? Because if he says what causes visual loss in a diabetic, it is macular edema. But if he says blindness, then it is neovascularization. The reason for this blindness can be two. One is that these blood vessels can rupture, so they can be a risk of development of vitreous hemorrhage in an individual. And over and above this, apart from the risk of vitreous hemorrhage, they can be retinal detachment. And because you know that this can happen in a diabetic, so I have to be wary. And therefore, the advantage would be that we will send up this patient. I mean, we'll set up consultation of this patient with an opthal guy so that we can progress and proceed with the pan-retinal photocoagulation. The heat of that laser beam will destroy these abnormal blood vessels. So pan-retinal photocoagulation with injections of bevacizumab. These would be intravitreal injections that would be given to this patient. And once I give this bevacizumab injections to this patient, this is gonna help me in preventing formation of new blood vessels. See, I said pan-retinal photocoagulation will destroy the blood vessels, but then bevacizumab, what it will do is it will prevent the further development of new blood vessels. Time taken for progression of diabetic retinopathy. In type 1 diabetes, it will usually take about approximately 5 years. And in type 2 diabetes mellitus, it will take approximately 15 to 20 years. So as such, I can say like this is a long-term complication, but is a preventable complication. And all of this can be prevented best by good HbA1c control. I mean, if I keep HbA1c of the patient less than 7%, problem like this would never not have happened if the patient never listened to us. He has also asked like what blood test can be done, because we are talking about fundus examination. He has said what blood test can be done to monitor the progression of diabetic retinopathy. The question was very peculiar. Fundus examination, understandable. He said blood test that can be done. Then we can do two of them. One is serum creatinine and second is serum homocysteine. Now, in a question where both have to be asked, and both are given in the options, and he says select single best answer, then don't answer creatinine because creatinine will take some time to rise, but serum homocysteine would be earlier to rise. So if he says monitor the progression, it was a very peculiar question, I think, that came in INISET exam, where he said how would you, this is actually a research by data only, that he said monitor the progression of diabetic retinopathy in a patient of like type 2 diabetes, where it will take 15 to 20 years. Then there are like two approaches, homocysteine and serum creatinine. Ideally, he says both should be used in conjunction, and I should also be using online softwares to measure estimated GFR, because if kidney is failing and eyes are failing, both the progression of retinopathy and nephropathy occurs at the same speed. I mean, if a diabetic patient is having retinopathy, he is bound to be having a nephropathy, and vice versa also. As far as the nephropathy part is concerned, I've discussed that in the kidney section, but here I'm just mentioning before you that if he says what is the earliest finding in a diabetic nephropathy, then your answer would be given as hyperfiltration. That is, the estimated GFR will be more than 125 ml per minute due to efferent arteriolar constriction. If he says histological findings seen, see, in clinical practice, nobody is going to be using a kidney biopsy for diagnosis of diabetic nephropathy. This is only for academic reasons that I'm discussing with you, that the most common histopathological finding is diffuse glomerulosclerosis. If he says what is the most characteristic one seen, then you will say nodular glomerulosclerosis. And in some MCQs, you will notice that instead of saying nodular glomerulosclerosis, the word written will be Kimmelstein-Wilson change. So the main message is that in real practice, nobody does a biopsy for diagnosis of diabetic nephropathy. In reality, the test that is done is urinary albumin creatinine ratio. Either I will be writing the word urinary albumin excretion rate, or I will be just saying the word albumin creatinine ratio. I'll be writing like both of them here. ACR is sometimes the term that can be written. In the numerator will be urinary albumin, and in the denominator will be urinary creatinine, and we'll take a ratio of this. And if you ever read a report which says 30 to 300 milligram of albumin present per gram of urinary creatinine, it is urinary creatinine. That means damage has already occurred. When I tell this to my patient, he's laughing on me, saying, "Sir, my serum creatinine is normal." On Diwali festival, there was a complimentary health camp by some lab company in my society. I got my complimentary blood test done. My serum creatinine was normal, and I'm sitting before you, talking to you. You're telling me my kidney is damaged. He says, "Sir, are you just trying to rip me off?" I'll tell him that I agree that serum creatinine is a very good test, but serum creatinine rises very late, very late. I want to make an early diagnosis, that is with help of urinary albumin excretion rate. And I would also inform him that nephropathy and retinopathy occur at the same speed. I mean, if he's having retinopathy, then there could be possibility of nephropathy and vice versa. And for monitoring progression in this particular case, obviously I will be checking the estimated GFR of the patient along with this urinary albumin creatinine ratio, UAC, I mean urinary albumin creatinine ratio, or it can be written as albumin excretion rate, can be used for monitoring the progression of the disease. We'll start this patient on ACE inhibitor with SGLT2 inhibitor. Additional drug which I want you to remember is Finrenon. Now this is a cousin of aldosterone antagonist like spironolactone, or like traditionally we read about eplerenone or we read about spironolactone, but this aldosterone antagonist has also been shown to reduce the progression of diabetic nephropathy. We should stop metformin, as I've explained to you, if the GFR of the patient is less than 30 ml per minute, and start the patient on insulin because organ damage is documented. And whatever insulin that is given, insulin is also excreted via the kidney. insulin is excreted by the kidney. So insulin should be started at 80% of the calculated dose. Yes, guys, because insulin is also excreted by the kidney. So the total dose of insulin to be given to this patient would be 80% of whatever is calculated on the basis of the body weight of the patient, due to the reason that I mentioned, that insulin is also excreted by the kidney of the patient. I'll repeat the fact once again. Diabetic nephropathy, peculiar thing, earliest finding, hyperfiltration. If he says, what will you do to reduce the progression? Obviously, SGLT2 inhibitor is obviously one of the primary things, but ACE inhibitor and finerenone are also to be remembered. And then we have to, like, switch from metformin to insulin. I'll explain to the patient, sir, enough is enough. You've already organ damage is occurring. So if you want to go like this, then you will have requirement of transplantation. Most common cause of kidney transplantation in India and America, and the most common cause of requirement of hemodialysis is nephropathy. I've not written it here because that is discussed in the kidney section as well, but I'll reiterate the statement. Number one cause of kidney transplantation in India and America is diabetic nephropathy. Few words about diabetic neuropathy as well, which has already been told to you as overall the most common long-term complication of diabetes mellitus. In fact, in diabetic neuropathy, they've asked what is first to be involved. Like the options were sensory, motor, and autonomic. So your answer would be that it is first sensory, then it is motor, and then it is autonomic involvement that will be seen. As far as the sensory involvement is concerned, your answer will be that it is distal sensory loss that will be occurring. So a large number of diabetics, when they're walking about bare feet and they're having distal sensory loss, there's a possibility that they might slip on us in the bathroom because the floor of the bathroom was wet, and they can end up with a subdural hemorrhage as well. Over and above the distal sensory component, sensory loss component, what you need to remember is that in this disease, the damage is not occurring to the large nerve fibers. It is damage to the small nerve fibers, that is unmatted C fibers, which is why it is also taken to be an example of small fiber neuropathy. The MCQ will say small fiber neuropathy, that is diabetic neuropathy. Over and above this, like I can say that these patients, especially at night time, they'll be having pain, they'll be having paresthesias, they'll be having discomfort in the feet at night, and because of this pain and the paresthesias component, they'll not be able to sleep at night. So disturbed nighttime sleep is very common in diabetics due to burning sensation or pain or paresthesias perceived in the feet. And therefore the question will say, like, what drug can you give for management of this discomfort at night, which is affecting the sleep pattern of the patient? Your answer would be you could be using duloxetine. Along with duloxetine, another molecule that can be used is gabapentin. I mean, they are one of the common molecules that would be used for any patient who's having nerve pain. Then as far as the motor involvement is concerned, there was a question in NEET PG which said, what is the most common cranial nerve involved in diabetic neuropathy? Your answer would be that it is third cranial nerve that is involved. It is oculomotor nerve that is involved. So third nerve palsy with papillary sparing. Get that word right. It is not plain third nerve palsy with papillary sparing. That means the light reflex of the patient would still be preserved. Third nerve palsy with papillary sparing should be remembered by you as one of the commonest cranial nerve involvement that you've seen. And then autonomic involvement can contribute to postural hypotension. And the definition of postural hypotension is what I would like to just brief for you. Postural hypotension means that first we will check the BP of the patient in supine position. Then we will check the BP of the patient in standing position. We'll not check the BP immediately. We will wait for 3 minutes for the compensatory mechanisms to act. Now, if the systolic BP of the person falls by more than 20 millimeters, and the diastolic blood pressure of the patient falls by more than 10 millimeter of mercury, then we will say that the person is having postural hypotension. Ideally, we should be doing a tilt table test, but we may not have that facility for the same in India. So it is like supine, then standing with a time lag of 3 minutes in between. And if there is postural hypotension, because the person can fall also, so he can say what drug can be given in this case so that you can prevent this kind of a mishap from occurring. So midodrine is a drug. It's a alpha 1 agonist. It will cause vasoconstriction and would be used for postural hypotension. 3 MCQs is what I've covered here. Distal sensory loss due to is the one of the earliest manifestations among the 3. The cranial nerve involved is third with pupillary sparing. Plus you can have diabetic diarrhea, constipation as well. But then it is postural hypotension which can rather trigger a fall in these patients as well. Then skin involvement can also be seen. So one of the skin involvement can be called as diabetic skin spots also. This could be melanin deposition in the skin. So lots of time you could be having like brown macules that would be seen over the shin of the patient. this would be written as diabetic dermopathy. If they just give you an image of macules which are like brownish macules on the shin of a diabetic, then it is diabetic dermopathy which should be answered. But if he specially mentions type 1 diabetes, especially a female in the third decade of type 1 diabetes, and she's having lesions on the shin where he mentions atrophic center containing telangiectasia, then don't answer diabetic dermopathy. Then answer would be given as necrobiosis lipidoica. I repeat my statement. If it just says brownish macules on the shin, that diabetic shin spots are like diabetic dermopathy. But if he specifically says woman type 1 diabetes in the third decade, like this was a young girl diagnosed as diabetes mellitus type 1, landed up in ICU due to decay, and now she's 30 years of age, then there are lesions with central area having atrophic center with telangiectasia as a description, necrobiosis lipidoica. And in case it is like acanthosis nigricans, then it is never a problem. I mean, that would be insulin resistance. And this has been discussed separately also, even in, I would say, metabolic syndrome. I've spoken about it. So acanthosis nigricans is something that we see not only with type 2 diabetes and PCOD, but even in patients of metabolic syndrome, which was an MCQ in the exam where there was no mention of any type 2 diabetes or insulin resistance. So let's focus on a question here. The question said 10-year-old child with type 1 diabetes presents to the ER with altered mental status. The diagnosis of decay is made. There's a thready pulse with acidotic breathing. That means small breathing. The potassium of the patient is low. Insulin sends potassium inside the cell. So probably that is what he's trying to ask us. He says, what is the most appropriate next step in the management of the patient? One is normal saline bolus followed by normal saline drip with KCl. Makes sense because potassium needs to be given. Potassium is very less in the body, and because the thready pulse is present, so bolus of saline would also be required. So this looks like a good answer. Let's look at B. Normal saline infusion for 1 hour along with KCl, followed by insulin drip. You see, this is also looking like a good answer, but I'm ruling it out. Why? Because patient's pulse is thready now. If the pulse of the patient is thready, if the BP of the patient is becoming less, is acidotic, I first need to give a fluid bolus to make the blood pressure recordable in a patient. So B would be valid. If this thready pulse was not given, then B would have been a decent answer. Let's look at C. Insulin drip with a bolus of KCl. Well, we don't start with the insulin drip now. The treatment is not started with insulin drip. First, we have to give normal saline to a patient. So C is wrong. D says discontinue the use of insulin drip due to low potassium level. That is what most people answered, casually in the exam. Question was saying, what are you gonna do? He's not asking some rationale. Obviously, like I will not give insulin drip if potassium is low. That is understandable. Question. He was not asking that what will you not do in the patient. He said, what will you do in the patient? Anybody with thready pulse, if I get a thready pulse, I first need to make the pulse recordable, which is why the correct answer to this question is option number A. And this was like widely debated, but this is the answer, guys. Don't answer as D because he's asking you intervention, he's not asking you what would not be done. So at this moment, I can say that this was fairly a long discussion that we had, but I hope that we were able to go through the important drugs aspect, the special focus on drugs that improve cardiovascular mortality, then drugs that are renoprotective as well, including the long-term complications of diabetes were revisited again. So keep the pressure on, keep studying like this, the same enthusiasm. I know you're tired, but then you need to keep the tempo up and keep the pressure on so that you are able to excel at the final time in the exams as well. Thank you so much for hearing me out.